Assalamu alaikum everyone. My name is Salma Metwally. I'm a fourth year medical student, and today, inshallah, we will be covering all of the GIT microbiology crash course. So we'll be going over the bacteria, viruses, parasites, and two other topics, which are food poisoning and antibiotic-associated diarrhea. Okay, before we go into the microbiology aspect, let's talk basics first. What is diarrhea? According to WHO definition, diarrhea is passing liquid or watery stools at least 3 times in a 24-hour period. Okay? But that does not mean that this is a strict definition. So the consistency of stool is more important than frequency. So even if someone tells you, okay, my stool is way more watery than usual, even if it's not more than 3 times, the fact that it's more watery than usual suggests diarrhea. Another thing is that if the diarrhea is associated with blood and mucus, we call this type of diarrhea dysentery. Okay? And it's important to know the difference between these two because they suggest different underlying mechanisms. Now, what are the underlying mechanisms? The diarrhea, specifically infectious diarrhea, can be due to one of three mechanisms. Either the presence of the infectious agent, just it being there at the mucosal surface, causes the diarrhea, and it could also be due to destruction of the brush border by the presence of this organism. Okay? Another thing is a toxin. So if a bacteria, for example, produces a toxin, this toxin will result in diarrhea. And the last mechanism is invasion. If the organism at the intestinal mucosa starts to invade and go into the mucosa, this could cause diarrhea. And what's special about this invasion is that the diarrhea will have blood. Okay? Think of it as the organism is going through the wall, destroying it, and there's going to be a lot of blood and mucus. It's going to be more of an inflammatory kind of diarrhea, okay? Or dysentery, as we said in the previous slide. Now, we also have the fact that there's an infection and an inflammation, so the host's immune system will start to mount an inflammatory reaction and cause systemic effects. So you have the diarrhea, and you may have other symptoms all around the body that are due to the inflammation that results from the infection. Now, as we said in the previous slide, we have different mechanisms. So each of these mechanisms that we talked about here will result into a different picture of diarrhea. Okay, as we said, the invasive diarrhea will be more inflammatory, so it will have blood, okay? And this is in contrast to the watery diarrhea, which is more associated with the toxin production. So if you have toxin, it's a watery diarrhea, and if you have invasion, it's a bloody inflammatory diarrhea. These are some organisms that are associated with each of these two kinds of diarrhea. We'll go over all of these in today's lecture, inshallah. And finally, you can have a chronic kind of diarrhea with some infections, especially Giardia, okay? Know this one. It causes chronic diarrhea. We're going to talk all about all of these organisms in today's lecture. So what is the mode of transmission? It makes sense that it's fecal-oral, okay? You know it. If you get diarrhea, you probably got the infection by eating something bad, okay? Or by eating something contaminated. So fecal-oral is the main mode of transmission. You have other forms of transmission, like person to person, specifically when it comes to Shigella. And you also have fomites, especially in rotavirus and Giardia. And rotavirus, as we will see, is associated with diarrhea in kids who go to daycare and preschool. And fomites can be things like toys, okay? So if you have a kid that's infected with diarrhea and their hands are not clean, they touch all the toys around, and then another kid comes and puts this toy in his mouth, this kid now has the same infection because of the fomite, okay? Now, some important thing to keep in mind is that diarrheal diseases are the second leading cause of death in children under 5 years old and the leading cause of malnutrition in children under 5 years old. And this is especially true in developing countries, okay? So diarrhea can lead to malnutrition and death. Now, one key concept to know about diarrheal illness is that it's usually a clinical diagnosis, okay? So a lot of the times you don't even need to send a sample to the lab. Just by seeing the clinical picture of the patient, like the type of diarrhea they have, the pattern, how long the episode lasts, if there are any other associated symptoms, just seeing this clinical picture will usually lead you to a diagnosis. You don't need to send a lab. You only send a lab if you only send a sample to the lab if it will alter your management, okay? So, for example, you're not sure what agent this is exactly, and you're not sure if you should give antibiotic or not. In that case, you should send a sample to the lab because whether or not it's something that warrants you giving antibiotic will change your management. Another thing is if it's important for public health. This is if you have an outbreak in a town or a city and you want to identify the organism that caused that outbreak, you will send samples to the lab. Um, and you also send a sample if there's a suspicious or more severe presentation, like if the patient comes with diarrhea that is bloody or presenting with fever, sepsis, dehydration, if they've had recent antibiotic use because you would be suspecting a specific picture, and if the person is immunocompromised because these people, immunocompromised patients, are susceptible to a lot of different infections. So you would want to identify what exactly it is. So in these conditions, in these situations, you would send a sample to the lab. Otherwise, it's just a clinical diagnosis by what the patient presents with. Now, important things for the culture. It makes sense. You take this tool and you take this tool sample and you culture it, okay? You should make sure that the culture is examined within 4 hours of collection or within 30 minutes of collection if you're suspecting amoebic colitis. Okay, so point is don't leave it out for too long. Send it right away to analysis. These are some microbial agents of diarrhea. We'll go over some of them, not all of them. You don't need to know all of these by any means. Just know the ones that are in the lecture. I just included it here for completion's sake. Okay, so now we covered the basics. We'll go into the actual microbiology part of this, okay? Starting with bacteria, we're going to talk about cholera, salmonella, shigella, E. coli, and campylobacter. Okay, so I'll show you pictures of the organism, and I want you guys to identify what organism this is. Okay, I'll give you a few seconds. Okay, so this is cholera. Look at the rice water stool and all of these pictures. So we'll talk all about this. And this is another species of Vibrio, okay? And we'll talk more about this in a few slides. So if you've watched Sketchy, this is the Sketchy for cholera. And I'll point some things out and we'll refer back to this picture. So these are the rice fields for the rice diarrhea, rice water diarrhea. These guys are standing by the bathroom for diarrhea. And this GS over here has something to do with the pathophysiology as well as the camp over here. Okay? So some basics about cholera, which you know from POD. I'll go over these very quickly. So Vibrio cholera is a gram-negative curved comma-shaped bacillus. Okay, it is motile with a polar flagellum. It's fermentative, facultative anaerobic. It's oxidase positive, and it can tolerate a wide range of temperatures. Now, something you should know is that you isolate cholera on this specific agar, which is TCBS. Just know the name, TCBS. It's an agar for Vibrio cholera. Another thing is if you culture cholera on McConkey agar, it will be non-lactose fermenting, okay? Now, um, this is the TCBS agar, and you will see that if it turns yellow, then this is Vibrio cholera. If it does not turn yellow, then this is Vibrio parahemolyticus. Just know that this is another species of Vibrio, okay? But the main one that we're talking about today is cholera, which is this one. And you can see here the gram-negative curved bacilli, which are cholera. Now, we do have a lot of serogroups in cholera, but the main ones that you should know are serotype 01 and serotype 0139. Okay, these are specific, these are the cause of major pandemics. The other serotypes just cause mild symptoms, but these two are the ones associated with what we call cholera. Now, how does cholera cause the disease? It is a toxin-producing bacteria. Remember in the beginning when we said some organisms produce toxins? Cholera is one of them, produces a toxin. And this toxin is a complex made of two parts, A and B, okay? It also makes another toxin, which is co-regulated pilus, or TCPA. Now, the cholera has genes that are related to these toxins, which are CTX and TCPA genes. The TCPA, which is the pilus, is responsible for attachment, and the CTX gene is responsible for the cholera toxin. Okay, so again, cholera has two main things in its pathogenesis, the cholera toxin and the pilus. The pilus is for attachment, and the toxin is what causes the actual diarrhea. Okay, now cholera is found in salt water because it requires salt to grow, and these are um, just some information about cholera, not very high yield for you to know. But you should remember that the infectious dose is high. That means that you need a lot of bacteria to actually cause an infection because most of the organisms are killed by stomach acids. So in order for it to actually reach the intestines and cause disease, you need a very high dose of bacteria. Okay? Now, the mechanism of pathogenesis of cholera. So this is the cholera toxin, okay? We said it has two parts, the A subunit and the B subunit. B is for binding, so the B subunit will bind, and then the A subunit will actually cause the disease. So after the toxin binds, it will be endocytosed inside the cell, the enterocyte, okay? This is enterocyte in the intestine, all right? The B binds, and then it's taken inside, and then this phagosome will take it to the endoplasmic reticulum where it will be processed. The A part of the toxin will be removed and it will go to do all of its function. The main thing that the A subunit does is it attaches to this ADP ribose, okay? It attaches to the uh, G protein of adenylate cyclase and activates adenylate cyclase to produce more cyclic AMP. If you remember from basic biochemistry, adenylate cyclase is an enzyme that produces cyclic AMP. What the toxin does is that it goes and activates adenylate cyclase to make so much cyclic AMP, and the cyclic AMP will then it will push out the chloride and all of these ions out into the lumen. Okay, so you have increase in cyclic AMP that causes all of these electrolytes to go into the lumen, and when these go into the lumen, they will absorb or attract water into the lumen with them, and this causes watery diarrhea. Okay, so B subunit binds, A subunit activates the adenylate cyclase, causing cyclic AMP to increase, leading to the electrolytes going out into the lumen with water following them. Now, as we said, most of these diarrheal infections are clinical diagnosis, and this is true for cholera. You see a patient coming in with this classic picture, you would say that this is cholera, okay? The diarrhea is profuse, it's painless, it's watery, and it's referred to as rice water stool because it looks like this. If you've ever washed rice in water, the water will then, like full of all the starch and stuff, it will look whitish. This is how it looks, okay? They also get abdominal discomfort, increased peristalsis. They may get vomiting, but important for you to know is that there is no fever, okay? It's just diarrhea without fever. There are some severe cases called cholera gravis, and these could prevent with hypovolemic shock because the diarrhea is very profuse. They're losing so much fluid in the stool, okay? So they may get hypovolemic shock. Okay. And there's another condition called cholera sica, where basically they're, forming all of this watery stool, but it's not leaving as diarrhea. It's staying inside the stool. It's kind of trapped, okay? So there's so much water and stool inside the intestine trapped there, okay? So this can cause the body to become in so much stress, and the patient might die even though they haven't even had diarrhea yet, okay? It's just because all of the stool is in the intestine, filling it up, and could lead to death. So this is cholera sica. Now back to the sketchy. Remember, we said the GS, which the toxin binds to, leads to the increase in cyclic AMP, okay? And it leads to this rice water stool. This is the shape of the cholera. It's gram-negative, so it's red and it's curved. And these are the most important things for you to know. Um, okay, now next organism. We're looking at the yellow side of this culture, the lactose negative. Okay, this is Shigella. So again, back to sketchy. This is the sketchy picture for Shigella. I want you to remember this cannon with the M on it. I also want you to remember this stool. And yeah, we'll refer back to this picture. Okay, so Shigella is a member of the Enterobacteriaceae family, and what this family is basically gram-negative bacilli that are oxidase negative and can reduce nitrates. Okay, so this is a feature of all of the Enterobacteriaceae, one of which is Shigella. It's a facultative anaerobe. It's non-motile, non-spore forming, non-encapsulated. Non-motile, if you look back at Sketchy, do you see this chain that the chimpanzee is held down by? This is to indicate that it's non-motile, okay? And it does require a selective medium for isolation. We can use a McConkey agar. It will be non-fermenter for lactose, so it's negative. So if you look at the McConkey agar over here, this lactose negative, the yellow side, this is Shigella, okay? You can also use a Salmonella Shigella agar, and you use a xylose lysine deoxycholate agar. And this XLD agar is selective, okay? And this is what the XLD agar looks like. This is selective for Shigella. Now, this needs low dose to require to get an infection. This is in contrast to cholera, which we said you need a high dose because a lot of it gets destroyed by the stomach acid. So in cholera, you needed so much bacteria. In Shigella, you only need very little bacteria to actually cause an infection because it can easily pass. It does not get destroyed by the stomach acids. And we have different species of Shigella, Shigella dysenteria, Flexneri, Boydii, and Sonai, okay? The most virulent one that we should remember is Shigella dysenteria, okay? This is the most virulent, and this specifically is serogroup A. Now, the pathogenesis of Shigella. Basically, Shigella, remember if you go back to this picture, look at the stool, it's full of blood, okay? Blood means that there's inflammation and invasion of the mucosa. So Shigella involves invasion of the mucosal cells and a lot of inflammation, okay? So this is the bacteria, okay? It goes to the M cells. Now, back to normal histology. This is an intestine, all right? This is the mucosa. These are enterocytes, and these are M cells, okay? Now, Shigella will first go into the M cells. It will be taken into the M cell, and then it will be taken up by macrophages. When it goes into the macrophage, it will not be destroyed by the phagolysosome. Shigella can go into the macrophage and just sit there and hide inside. It stops the lysosome from destroying it, so it can just live inside the macrophage. And then it will go out of the macrophage into the nearby enterocytes, okay? Where it will then be able to like be pushed from one enterocyte to the next. So basically it goes into M cell, taken up by macrophage, and then from the macrophage it will keep going into the enterocyte from one enterocyte to the next. It will just like move sideways between the enterocytes. Let me get the pointer. Okay. And if you remember the this M cannon, this is how it moves from one cell to the next. Okay, the M is for M cell. First it goes into the M cell, and then it will move from one cell to the next, kind of like a cannon. Look at it. It's like going like, it's being pushed. So another thing other than this going into the cells is that you have destruction of the tight junctions. Okay? So as this Shigella bacteria is moving from one cell to the other, as the cannon, if you look at this, it looks like a cannon. On its way, it's destroying the tight junctions. And when that happens, now you've created another entry port for the bacteria to go. Okay, so it's going from one cell to the other, and it is going through the tight junctions which got destroyed. And as it's doing that, it's inducing so much inflammation, leading to all of the inflammatory diarrhea. Okay, and so inflammation, death of the epithelial cells, as well as ulcerations. So inflammatory, bloody diarrhea, and ulcerations. Other than this invasion, which is the main way by which it works, we have some toxins, okay? Enterotoxins. The plasmid encoded SHET2 and SHET1, which is chromosomally encoded, as well as Shiga toxin. These toxins will cause diarrhea in the way of enterotoxins, leading to like all of the solutes and water going into the lumen, but it's very minor. The main way by which Shigella causes diarrhea is this invasion. And that's why the main diarrhea caused by Shigella is a dysentery or an inflammatory bloody diarrhea. So mainly know the invasion, okay? Okay, Shigella is the most communicable bacterial agent of dysentery, and it causes acute diarrhea. It may be watery, but mostly it is bloody mucoid, but diarrhea with a small amount of fecal matter. Why is it small amount? Because Shigella goes to the large intestine, okay? Any diarrhea that originates in the large intestine is only a small amount of fecal matter. This is in contrast to anything in the in the small intestine. Small intestine is very high volume, like cholera. Large intestine is a small volume, like Shigella. And most of the time it is bloody with mucus and is associated with something called tenesmus, which is pain with defecation. So tenesmus, bloody mucoid diarrhea. A complication of Shigella infection is hemolytic uremic syndrome, which is due to Shiga toxin. Remember how we said that Shigella has some toxins, these ones? Now, these are not very prominent in the way it causes diarrhea, but one of the complications of the Shiga toxin is that it may lead to hemolytic uremic syndrome, which has to do with the kidneys. You don't really need to go into details, just remember that it could cause problems in the kidneys, okay? This is the diarrhea or the dysentery caused by Shigella. You can see there's so much blood, it's mucoid, and it's not very high in volume. It's a small amount of stool. Okay, back to the sketchy picture. So remember the M cells, remember the cannon, and I did forget to mention, the cannon is actually the actin polymerization. So basically what's pushing the Shigella, because remember, it's non-motile, okay? Remember the chain around the chimpanzee, okay? It's non-motile, so it needs something to push it. And what's pushing it? Actin polymerization. You know, actin is the cytoskeleton of the cells. It will polymerize and push the Shigella out of the cell into the nearby enterocyte. Okay? It's just something that I forgot to mention. And back to this. So the stool that the chimpanzee is sitting on is for the bloody stool because it's red. And this is a glomerulus for hemolytic uremic syndrome. Right. Now next organism. This is Salmonella, and specifically with these presentations is typhoid fever. This is a Salmonella Shigella agar. These are rose spots specific to typhoid fever, and this is pea soup stool, also for typhoid fever. This is the Salmonella sketchy. Just remember it, we'll go back to it. Some key features of Salmonella is that it's a gram-negative motile bacilli. It has three major antigens, H, O, and VI. The H antigen is for the flagellum, O antigen is the somatic antigen, and the VI antigen is the capsular polysaccharide. Now, this VI antigen is important because it is the key virulence factor of Salmonella. Okay? So, H antigen, O antigen, and VI antigen. VI, which is the capsular polysaccharide, is the virulence factor. Why? Because it's antiphagocytic. So, it prevents the phagocytosis and destruction of Salmonella. It's like a protection for it. It's only possessed by a few types of Salmonella, like Salmonella typhi and Paratyphi. And this is why Salmonella typhi and Paratyphi cause a distinct disease, which is typhoid fever. Okay? It also has lipopolysaccharide because remember, it's gram negative, and gram negatives have lipopolysaccharide in the envelope. So we have antigens, The main one you should remember is the VI antigen, capsular polysaccharide, because it's the virulence factor and is antiphagocytic. Okay, now what is typhoid fever? Okay, so Salmonella is the bacteria. It can cause different kinds of diseases. One of those diseases caused by Salmonella is typhoid fever. What is typhoid fever? It's a systemic intracellular infection characterized by bacteremia and reticuloendothelial cell involvement. So you first get the Salmonella, the bacteria, through the GI, and then it will go into the blood, causing bacteremia, and then move to the reticuloendothelial system. The main feature of this disease from the name is fever, okay? Specifically, what's special about this fever is that it's a step ladder fever. And something very important is bradycardia. So if you know anything about fever, okay, usually if someone has a fever, they have tachycardia. In typhoid fever, something different and unique is that the fever actually presents with bradycardia. And this sign is called Figet's sign, okay? Um, they also present with constipation preceding diarrhea. So they may get constipation first and then they will develop diarrhea later on. They also get rose spots on the trunk and abdomen, which we saw here, okay? These rose spots. And they get pea soup stool, which we also saw over here. So, one more time, step ladder fever and bradycardia, rose spots, and pea soup stool. Those are key features that you should look out for, especially in questions and case scenarios. You need a lot of bacteria for it to actually cause disease because it's destroyed by gastric acid. And as we said in the previous slide, the typhi and paratyphi are the ones that cause typhoid fever, and you can guess from the name, typhi for typhoid, paratyphi for typhoid fever, okay? And these two species are special because they have the VI antigen. So the VI antigen is the virulence factor, and it's what caused these two species to be able to cause typhoid fever. And one more thing, very important, transmission. You get it from contaminated food because, it's in GIT microbiology, so obviously it has to do with the GI, and anything in the GI you get from contaminated food. One specific group of animals or food that you should always think of when you think of salmonella is poultry products, chicken, eggs, especially chicken and eggs. But you can also get it from red meat, unpasteurized milk, or contaminated water. But the main two things, chicken and eggs, okay? Now, this is the pathogenesis. So back to the intestine, we have the M cells, we have the tight junctions, and sorry, these are the M cells, okay? These are enterocytes and these are M cells. And again, the macrophage. So the Salmonella typhi, first it goes into the M cell, and then it goes into the macrophage. Inside the macrophage, remember, it has an antiphagocytic function. So it can sit there and not be destroyed by the macrophage. Then it will go into the lymph nodes, from the macrophage into the lymph nodes, and then go into the blood. This is the bacteremia that we talked about here, okay? And then as it goes into the blood, it will go into the reticuloendothelial system, as we said over here. And the reticuloendothelial system is basically the spleen, the liver, okay? So it goes into the blood and then to the spleen and the liver, and then it can go to the gallbladder and stay there, okay? And if you know the story about Typhoid Mary, basically she worked in a restaurant and she was spreading this typhoid fever to patients unknowingly because she had the Salmonella typhi, in her gallbladder just hiding there, and she didn't have any symptoms, and she was spreading it to everyone around her, okay? So from the gallbladder, it can go into the Peyer's patches, also in the intestines, and re-enter the GI tract. And when it goes back into the GI tract, it can cause a secondary exposure, okay? So main thing for you to know is that it will go in, taken up by the macrophages, then go into the blood and spread to the reticuloendothelial system. Okay, so all right. We have some pathologic events that happen in typhoid fever, and you should know what things are related to them. So we know that it goes into the blood and it will be taken up by the macrophage. What allows it to go into the immune system and the macrophage is the fact that it has the VI capsular polysaccharide because it's antiphagocytic and it will not allow it to be destroyed by the macrophage. Now, the other event is that it can invade. Remember here, it invaded to go inside into the macrophage, and it invaded the M cells. And this M cell is what allows it to enter. Remember, which bacteria also enter through the M cell? Shigella. So Shigella and Salmonella both will enter into the M cell. And again, it goes into the macrophage, does not allow it to destroy it. Then it will spread systemically, okay? So it will infect the macrophage and go through the blood. We get the bacteremia, and then it will go to liver, spleen, bone marrow, gallbladder, basically the reticuloendothelial system. Then you get sustained bacteremia. So it's kind of just always going through the blood and the reticuloendothelial system. It's replicating there, it's living there, doing all that. You also have a chronic carrier state. Remember, typhoid Mary, okay? Gallbladder colonization. So the Salmonella typhi will go into the gallbladder, colonize, stay there. The person will not have any symptoms, but they are carriers. They can spread the infection because it will be shed in the bile and go into the stool and then eventually reaching other people around them, okay? A major complication of typhoid fever is Peyer's patch hyperplasia. Okay, remember what we said here. If it's staying in the gallbladder and then it's being shed into the bile, will go back into the intestine and cause a secondary exposure. This secondary exposure is where basically it leads to the Peyer's patches becoming so big. So after they go into the gallbladder, get stored, go back into the bile, then they make the Peyer's patches get big and hyperplastic, eventually becoming necrosed. And this hyperplasia and necrosis of the Peyer's patches can lead to intestinal hemorrhage and perforation. Now, remember how we said here that they may get constipation before they get diarrhea? The cause for that is when they have Peyer's patches hyperplasia, they get so big that they block the intestine, and they can like when they get so big, they cause constipation because they're blocking the intestine and the outflow of stool, okay? That's why they get constipation and then it will be followed by diarrhea. But the main things you remember in typhoid fever is the stepladder fever with bradycardia and the rose spots on the trunk and the abdomen and the pea soup stool, okay? These key features are very important for you to know because they will be the key characteristics in questions that you should recognize and know that they're talking about typhoid fever. And this is pea soup, in case anyone was wondering. I don't know if it looks like this tool. Sorry if you liked pea soup. Maybe that's the for you now, but yeah, at least remember this key description. Now, how do you isolate salmonella? You get specimen from where? You can get it from stool, you can get it from blood, bone marrow, because remember, the bacteria is going into the blood, it's going into the liver, the spleen, the bone marrow, all the reticuloendothelial system. So you can get samples from any of that. Stool, blood, bone marrow. You can also get a skin biopsy from the rose spots. These spots, you can get a biopsy from them. And you isolate the bacteria on McConkey agar. This is not selective for salmonella, but salmonella will be non-lactose fermenting. Okay. A selective medium is Salmonella Shigella agar, and Salmonella will be black colonies. Shigella, on the other hand, if you isolate it on this agar, it will not be black. If you see black colony on Salmonella Shigella agar, this is Salmonella. Why is that? Because you have hydrogen H2S, and basically it will ferment it to get ferrous sulfide, and this ferrous sulfide is what gives the agar the black color. So which one is black on the agar? Salmonella. Okay, back to the sketchy. You have chicken. You have the macrophages over here because it's a key part of the pathogenesis. It goes into the macrophage to hide, then be spread around the body. Okay, and this match for fever, typhoid fever. All right. So the difference between typhoid fever and acute bacterial gastroenteritis because, as we said, the salmonella can cause a lot of different diseases. The one we talked about is typhoid fever. It can also cause acute bacterial gastroenteritis. The difference is that typhoid fever is more insidious in onset. It takes a long time to develop, while the gastroenteritis is more abrupt. Again, remember the fever in typhoid fever is more stepwise, okay? And it has bradycardia, while the gastroenteritis will have tachycardia. So fever with bradycardia is typhoid fever. And then all of the other symptoms that we talked about, these won't really be seen here because you won't see the constipation. It will just be diarrhea and gastroenteritis. And the pea soup is characteristic for typhoid fever. Um, yeah, I think that's all you should know. Also remember the rose spots and the fact that it goes into the reticuloendothelial system for typhoid fever. Okay, next organism. We're looking at the question mark over here, the pink side. Okay, this is E. coli. So again, sketchy for E. coli. I want you to remember the red stool over here, this chimpanzee toy, the $157 over here. I also want you to remember the van. Remember LA and SG, okay? And talk we'll come back to this picture again. So E. coli is gram-negative motile bacillus. It's also a member of Enterobacteriaceae. I think this is a typo, my bad. It's oxidase negative, indole positive, and this one, in contrast to all the other ones that we discussed previously, this one ferments lactose. So it forms pink colonies on MacConkey agar. Okay, remember the MacConkey? All the other ones that we talked about previously did not ferment lactose. E. coli is a lactose fermenter, so it will be pink on MacConkey. Okay, one of the species of E. coli, or the seer groups of E. coli, is O157H7. We'll talk more about this in a few slides, but just remember that this one cannot ferment sorbitol on sorbitol MacConkey agar. So we have the normal MacConkey agar with lactose. All E. coli will ferment lactose on this agar and become pink. But then, if you add sorbitol onto this agar, you add sorbitol to differentiate O157H7 from other types of E. coli. This specific O157H7 cannot ferment sorbitol, while all the other E. coli will be able to ferment sorbitol. So sorbitol negative, basically it will stay yellow, okay? If you add sorbitol and it does not become red, okay, this is sorbitol negative and it's E. coli O157H7. If it does ferment sorbitol, then it's any other type of E. coli except for this one. Now, how do we classify E. coli? It's classified based on serotypes. We have O antigens and H antigens. Remember, O and H, okay? These are antigens. And we also classify E. coli by the type of syndrome or disease that they cause. Now, we have commensal E. coli and pathogenic strains of E. coli. So some E. coli just live in the microbiota. It is part of the microbiota. The difference between them is that pathogenic strains have fimbria. These fimbrial antigens allow it to colonize and adhere to the mucosa, causing diarrhea. Okay? So commensal strains versus pathogenic strains. Pathogenic strains have fimbria to allow it to colonize and adhere and cause diarrhea. Commensal strains don't have these fimbria. These are all the strains that are pathogenic. We have EHEC, EIEC, EPEC, ETEC, all of these. We're going to talk all about these in the coming slides, okay? Each one of these strains has its own pathogenic mechanism. Okay, let's start with the first one. First one is enterotoxigenic E. coli, or ETEC. From the name, enterotoxigenic. Toxi means it produces a toxin. So ETEC, pathogenic mechanism is enterotoxin production. Whenever you see enterotoxin, think watery diarrhea. Remember at the very beginning we said when there's toxin, it's watery diarrhea. When there's invasion, it's bloody diarrhea, okay? In this case, it's toxigenic. So there's enterotoxin and watery diarrhea. This type of E. coli is what's implicated in traveler's diarrhea, as well as diarrhea in children in developing countries. So if you have someone who traveled, traveled somewhere, that they're not used to living in, just went on vacation, they ate something suspicious from a sketchy, small local restaurant, and then they got watery diarrhea. Think of E. coli, specifically enterotoxigenic E. coli, okay? We do have two types of toxins, the heat labile toxin, also referred to as LT, for L for labile, and then heat stable toxin, ST, S for stable, okay? So heat labile toxin, heat stable toxins. They're both two different types of the same, types of toxins produced by this same E. coli, enterotoxigenic. Okay, what is the difference between these two toxins? The heat labile means that it's weak, it cannot withstand heat. Heat stable means that it's strong and can withstand heat. They have different mechanisms of actions, okay? Heat labile toxin targets adenylate cyclase. And when it targets that, basically, remember, adenylate cyclase leads to the production of cyclic AMP. And you have so much cyclic AMP, you will have release of electrolytes into the lumen, water follows, and you get watery diarrhea. Remember, which bacteria did we say has this exact same mechanism, adenylate cyclase and cyclic AMP? Cholera, okay? Remember the picture of Sketchy, the guy, like the military person with the GS on his pocket and carrying the map of the camp, okay? So the heat labile toxin of ETAC targets adenylate cyclase, leading to production of cyclic AMP, leading to the release of electrolytes. While the heat stable toxin, on the other hand, targets guanylate cyclase C, okay, leading to the production of cyclic GMP, and then you get a similar kind of endpoint, which is electrolytes going into the lumen. So if we look at this picture, this is ETEC. It produces the toxin, okay? This is the heat labile toxin, and this is the heat stable toxin. The heat labile toxin has a subunit and B subunit similar to the cholera. So it will bind and go inside in these vesicles, and then it will get the subunit A doing all the function. It will go to eventually reaching to adenylyl cyclase, okay, leading to cyclic AMP production and leading to electrolytes going into the lumen. On this side, we have the heat stable toxin. It will target the cyclic GMP, leading to, again, same thing, release of electrolytes into the lumen. Okay, so just remember, labile, cyclic AMP, stable, cyclic GMP. Okay, and if we correlate this back to the sketchy that we saw, okay, here, remember this truck, LA and SG, because heat labile is for cyclic AMP, and the heat stable is for cyclic GMP. So just remember LA, like Los Angeles, LA. So LA, labile for AMP, and then SG, okay? Okay, back to this. So we finished enterotoxigenic E. coli. The next type of E. coli is enteropathogenic E. coli. This specific type is what causes infant diarrhea in developing countries. And basically, the lesions are attaching and effacing lesions on intestinal biopsy. And you get the formation of something called a pedestal. So here we have intestine. These are microvilli, and these are the EPEC, okay, enteropathogenic E. coli. They go into the intestine and they go to the villi. They will squash the villi, just kind of like squash them down to form this pedestal, and then they will sit on the pedestal, okay? This is electron microscopy of this. These are villi, all right, and this is the pedestal. It's like a squashed villi, and this is EPEC, just sitting on the pedestal. So if you wanna remember this, EPEC has P, okay, and P is for pathogenic, but P is also for pedestal. So which type of E. coli has a pedestal formation? EPEC, okay. Next type of E. coli is enterohemorrhagic E. coli or Shiga toxin producing. So it's called EHEC. And EHEC is what has this special type 0157H7. This type of E. coli mainly affects infants and children, and it causes bloody diarrhea, but no fever. So, bloody diarrhea without fever. Remember what we said about 015787 is that it's sorbitol negative. We go back to this picture over here. This is sorbitol on McConkey. This is sorbitol McConkey sorbitol agar. The sorbitol negative ones, which don't change color, are 0157H7. And 0157H7 is the enterohemorrhagic E. coli. Again, bloody diarrhea because hemorrhagic from the name hemorrhagic because bloody diarrhea. And there's no fever. Now, what is the mechanism? It is the production of Shiga-like toxin. Remember how we said that Shigella produces toxins? They're not the main mechanism of diarrhea production, but they are significant. This EHEC also produces a Shiga-like toxin. And remember what we said about this toxin in Shigella is that it leads to the complication which is HUS or hemolytic uremic syndrome. This same syndrome can happen in enterohemorrhagic E. coli because it has the same toxin as Shigella, which is the Shiga-like toxin. What is the hemolytic uremic syndrome? It's a triad of microangiopathic hemolytic anemia, as well as thrombocytopenia and AKI. So just remember, if you have a kid that had a bloody diarrhea, okay, and then later on they developed kidney problems and kidney failure, okay, think of hemolytic uremic syndrome and think of the Shiga-like toxin produced by EHEC, specifically 0157H7. Something that you should remember is if you have someone infected with EHEC, you want to avoid the antibiotics, okay? Because the antibiotics may increase toxin release. So, if you have EHEC, do not give antibiotics. How does the Shiga toxin work? Basically, we have this molecule over here called GB3 on the surface of the enterocytes, okay? The Shiga toxin will attach to GB3 and then it will be taken inside, okay, endocytosed, and then it will prevent protein synthesis inside the enterocyte. And when it inhibits protein synthesis, it will lead to cell death. And this, when you have cell death, you have the destruction of the lining of the mucosa, you will have blood going into the lumen, okay? And this GB3 molecule here that allows the toxin to bind is the same one that is found in kidneys. So this same GB3 is found both in the intestine and in the kidneys, and this is why the same toxin can go to the kidneys and cause HUS. Okay, so remember, Shiga toxin eventually leads to inhibition of protein synthesis, leading to cell death, and the cell death is why you have hemorrhage, why you have enterohemorrhagic type of infection or diarrhea. The next type of E. coli is enteroaggregative E. coli. This is usually watery diarrhea, and it is there's presence of mucus. It may have blood, but not really, like it's not really the main picture of the disease. So the main thing is chronic watery diarrhea in children and immunocompromised patients. So this enteroaggregative E. coli is more so related to immunocompromised patients. And you get something called a stacked brick appearance. So from the name, enteroaggregative. So you have aggregation of bacteria. This is the intestine, okay? This is the brush border with the villi. This is the lumen. You have the bacteria coming in, and they will bind over here, and they will collect between the villi and the crypts, and basically aggregate together, okay? And this aggregation will disrupt the brush border, it will destroy the villi, squash them, push them down, stop their function, and they also have this biofilm being produced, so it will like block the villi. So you're disrupting the function of the villi, of the brush border, okay? And this aggregation, disruption of brush border basically leads to diarrhea. How? Because you know the normal function of the villi is to absorb nutrients and electrolytes and all that. If it can't do that, they will all stay in the lumen and attract water with them, leading to diarrhea. Okay? So the aggregation of the enteroaggregative E. coli disrupts the intestinal brush border, leading to diarrhea. And you get the stacked brick appearance in the intestine. The next type of E. coli is enteroinvasive E. coli. You have the word invasive, so if there is invasion, then there is dysentery or there is bloody diarrhea. So the pathogenesis of enteroinvasive E. coli is similar to Shigella. Remember, how did Shigella cause diarrhea? It caused it by invasion. So it went into the M cells and then it went into the enterocytes, leading to their destruction and invasion of the bacteria into the mucosa. Similar thing is happening here with the enteroinvasive E. coli. It has a similar pathogenesis. So the E. coli will penetrate into the enterocytes, it will cause lysis, and it will divide inside the cells, eventually destroying these cells and also extending into adjacent cells. So we have the M cell over here, okay, remember M cell, we saw it in Shigella. So the enteroinvasive E. coli goes into the M cell, into the macrophage, and then will go into the nearby enterocytes, divide there, move, be pushed into the adjacent enterocytes, destroying these cells, and eventually invading all of this with destruction and inflammation, leading to bloody diarrhea. Okay, this is very similar to Shigella. Remember the canon in Shigella? Okay, it's a similar mechanism. Now, what is the difference between enteroinvasive E. coli and enterohemorrhagic E. coli? Remember, enterohemorrhagic E. coli, the diarrhea is because of the Shiga toxin, but enteroinvasive E. coli, the diarrhea is due to the invasion. Okay, so enteroinvasive and enterohemorrhagic, both of them cause dysentery. They both cause bloody diarrhea. But enterohemorrhagic, the pathogenesis is the Shiga toxin, leading to inhibition of protein synthesis. This is enterohemorrhagic, okay? While enteroinvasive is because of a similar mechanism to Shigella, which is it going into the nearby cells, destroying them, and leading to destruction. So they both are similar to Shigella, but enteroinvasive has a similar mechanism to Shigella, okay? While enterohemorrhagic has the Shigella toxin or Shigella-like toxin. Okay, just know the key difference between these two. And we have another type of E. coli, which I think is the last one. Yeah, it's the last type of E. coli, which is adherent invasive E. coli. This one is more linked with Crohn's disease. Okay, you have from the name adherent invasive, so there's adhesion. Okay, it adheres, the E. coli adheres to the intestinal mucosa, and then it invades from the name invasive, and it will start to replicate and then destroy the barrier. Okay, so you have adhesion to the intestinal mucosa by binding to this CEA-CAM6, which is the carcinoembryonic antigen-related cell adhesion molecule 6. I don't know if you should remember this name. Just remember that it adheres to CCAM, okay? And be able to recognize CCAM if you even get this in a question. Or just know that adherent invasive E. coli is linked to Crohn's disease. I think this is an important connection, okay? After it adheres to the CCAM, it will invade the epithelial cells, and then it replicates intracellularly inside the cells and the macrophages and translocates across the barrier, moving to deeper tissues. So just know it's linked to Crohn's disease and it adheres to CCAM and then invades and goes through the intestinal mucosa. So this is again similar. You see the bacteria over here adhering to CCAM, going in, replicating inside, and then translocating across the mucosal surface. Okay. This is just a quick summary of all the different types of E. coli. Remember, enterotoxigenic E. coli because of the toxins. We have two types of toxins, labile toxin and stable toxin. And this is what causes traveler's diarrhea. This type of diarrhea, because there's a toxin, it is watery diarrhea. Then we have interinvasive E. coli, which has a similar mechanism of action to Shigella. Not the Shiga toxin, okay? It has a similar mechanism to Shigella. It invades and causes dysentery. Then we have the enteropathogenic E. coli. Remember P for pedestal formation. you have effacement of the villi, and you don't have a toxin. Then there's interaggregative E. coli. Remember the stacked brick appearance, and this is more so in immunocompromised patients. Then finally, we have EHEC, or enterohemorrhagic E. coli. This is where you see the Shiga-like toxin, and you have a specific serotype that causes this type of disease, which is 0157H7. I cannot emphasize how important this serotype is. Just know this term, okay? 0157H7. Know it and know that it's related to EHEC, Shiga-like toxin, and hemolytic uremic syndrome. And enterohemorrhagic E. coli from the name hemorrhagic, so there is bloody diarrhea, but no fever. And also remember that 0157H7 is sorbitol negative on McConkey agar. Just some last things. We talked about this mostly. It's gram-negative, motile bacilli. Yeah, we did talk about this. Okay, so back to the sketchy picture. On the side, we have 0157H7. Okay, if you look below it, we have this chimpanzee for the Shiga-like toxin, and the glomerulus over here, and the killed RBC for hemolytic uremic syndrome. And sorbitol, because this type of E. coli is sorbitol negative, and the red stool for hemorrhagic, enterohemorrhagic. And then remember on this side, we have we have the toxins in the enterotoxigenic E. coli, the labile for cyclic AMP, and the stable for cyclic GMP. Okay, now next organism. This is Campylobacter, okay? And this is sketchy for Campylobacter. Remember this chicken over here, okay? And the red stools. I'll come back to this. So we have two species of Campylobacter. We have Campylobacter jejuni and Campylobacter coli. The more common one that usually causes infection is Campylobacter jejuni. Campylobacter is gram-negative curved bacilli. It's oxidase positive, non-spore forming, it's motile, bipolar flagella, and it's non-fermentive. It is thermophilic, so it needs a higher temperature. You incubate it at a temperature of 42 to 43 degrees Celsius. And it's microaerophilic, so it needs very little oxygen when it's incubated. Okay. It can be isolated on selective media like Campi blood agar, Scaros agar, and Campylobacter charcoal differential agar. Now, how does it cause infection? First, you have chemotaxis, so the Campylobacter will be will go into the lumen, and then it will move through the lumen, and then it will use adhesion molecules to colonize on the surface of the mucosa. Then it will invade and translocate by penetrating into the cell. It will go into the cell and between the cells, okay? Transcellular and paracellular through the tight junctions. Then it will produce a toxin, which is called cytolethal distending toxin, CDT, okay? So this toxin, uh, it produces a toxin and it survives inside the cell. When it's found inside the cell and produces all of this toxin, this will all stimulate a host inflammatory response. So we have three main mechanisms in its pathogenesis. We have the enterotoxin, we have the CDT toxin, and we have the host inflammatory response to this infection. The enterotoxin that Campylobacter produces is gonna disrupt ion and water transport. Remember, anytime you have toxin, you have watery diarrhea because of disruption of ions. So enterotoxin from Campylobacter disrupts water and ions. Then the other part of pathogenesis is the CDT production, which is the cytolethal distending toxin. From the name, cytolethal, so it kills the cells. It leads to cell death. And this is what would contribute to a bloody stool kind of appearance. And then finally, you have the host inflammatory response, leading to ulceration and mucosal damage. So three things: enterotoxin, CDT, which is the cytolethal distending toxin, and host inflammatory response. Okay? Now, what kind of symptoms do they get? They get acute episodes of abdominal cramps, abdominal pain, and diarrhea. If If the bacteria mostly it produces enterotoxin, then the diarrhea would be watery. But if it's mostly producing CDT, it will be a dysentery because cytolethal toxin. Okay. What are the sources of infection? The most important thing to remember is contaminated chicken and chicken products. Okay. Chicken. Remember chicken. We saw chicken in Salmonella, and we saw chicken in Campylobacter. Campylobacter can also cause Guillain-Barré syndrome or reactive arthritis. It's kind of like um, an autoimmune reaction to this infection that leads to Guillain-Barré is paralysis type of appearance, and reactive arthritis, they get arthritis after being infected with Campylobacter. Okay, back to the sketchy. Remember the chicken. Remember here this guy laughing, hitting his knee for reactive arthritis. Remember the red stool for dysentery or bloody diarrhea. Okay, so if you also should remember the cytolethal descending toxin for Campylobacter, CDT. Okay, so we're done with the bacteria. Okay, now we will move on to viruses. We'll talk about rotavirus, norovirus, and enteric adenovirus. All right. Now, some key things about viral gastroenteritis. Viruses are the most common causes of gastroenteritis worldwide. So we have all of this talk about bacteria and we talk about it a lot and it's very significant. But the more common cause of gastroenteritis is actually viruses, okay, not bacteria. So viral gastroenteritis is more common than bacterial. These are some viruses that are associated with gastroenteritis, and we also have, other than viruses infecting the GI, we may have a virus causing systemic disease. And one of the complications or some symptoms of the systemic viral disease is getting GI symptoms, but the primary infection is not actually in the GI. Now, a very important feature of any virus that causes gastroenteritis is that it has to be a naked virus, because if it's enveloped, the envelope is very weak. Think of it as like, the normal envelope that you send in the mail, it's paper, okay? Paper is weak. If it goes into the stomach, into the acid, it's gonna get destroyed. So any virus that has an envelope cannot cause gastroenteritis because the stomach acid will destroy the envelope. You have to have a naked virus without an envelope to be able to bypass the stomach acid and reach the more downstream parts of the GI tract and actually cause gastroenteritis. So these are all naked viruses. Okay, our first viral agent. Okay, this is rotavirus. Rotavirus is a non-enveloped double-stranded RNA virus. Again, non-enveloped, as all of the viruses that we will talk about now do not have an envelope. They're naked. The rotavirus is double-stranded RNA virus. Think of rota, okay, has an R in it for RNA, okay? It's part of the Rheoviridae viral family, and it has a classic wheel-shaped appearance on electron microscopy. If you know the pirate ship, okay, and the steering wheel, it kind of looks like this. I forgot to get a picture of it, but if you've seen it, or you can look up a picture if you don't know it, the wheel is like a circle, and then it has like these knobs coming out of it, okay, for them to just like move it, okay? This is kind of how it looks. So it's a wheel shape, okay? Look at this circle, and then with these little like spikes or knobs coming out of it. This wheel shape is very characteristic of rotavirus. It has a double-layered protein nucleocapsid, and the genome is made of 10 to 12 segments. So this double-stranded RNA is made of segments. We classify rotavirus into serogroups. We have 7 serogroups, and the main ones that you should know that are related to human infections are groups A, B, and C. The most infective one is serogroup A, and we divide this serogroup A into serotypes. Okay, so we have rotavirus. Rotavirus is divided into serogroups. These serogroups have A, B, C, D, whatever. The most important serogroup is A. This A we divide into more serotypes, okay? So serogroup A is divided into serotypes based on specific antigens that it has, which are VP4 and VP7 antigen. Okay, so just remember the most virulent group of rotaviruses are is the serogroup A. Some epidemiologic features is that this is the number one cause of gastroenteritis in children less than 5 years of age. Okay, rotavirus is very important and it occurs worldwide, but it causes a more severe infection in non-developed countries because now we have a vaccine against rotavirus, and in developed countries, the vaccination is routine. Okay, so the infection still does happen, but it's not as severe as it would be in the non-developed countries without a vaccine or without routine vaccination. So in the developed countries with the vaccination, norovirus is actually now more common. This is another virus that we will talk about later. So when you think of a developing country, think of rotavirus. When you think of developed countries, think of norovirus. Why? Because we have a rotavirus vaccine. Rotavirus can spread very easily. Like if you have children infected in a daycare, it spreads all around the daycare so easily. Okay. And what's scary about this virus is that it is stable in detergents and over pH and temperature ranges. So they're very hard to get rid of. They're hard to destroy. And this goes back to the fact that it lacks an envelope, okay? Does not have an envelope, it's naked, which makes it stronger. And it can withstand detergents, a lot of pHs like acidity, high temperatures, so it's hard to destroy. So that's why it can spread easily. The main way by which it is transmitted is through the fecal-oral route. And it can also be on contaminated hands and fomites. Remember what we said about the toys being infected and kids like playing with the toys, putting them in their mouth. So fecal-oral route, because the feces, the kids don't clean their hands, okay? So their hands are contaminated, they contaminate the toys. So fecal-oral route, contaminated hands, and fomites. You can have repeated infections, okay? But if someone gets an infection, they have some kind of protection. This protection does not prevent repeated infection, but any subsequent infection that they get later on will be less severe than the first one. So they get an infection, they have some protection that makes any other infection they get later on less severe, but it does not prevent recurrent infection. How does the rotavirus cause diarrhea? Basically, it will go to the brush border. So again, enterocyte has these villi. The rotavirus will go to the villi and will cause villus atrophy. When you have destruction of the villus, remember, okay, villi, why do you have them? For absorption. If you destroy the villi, you lose the absorption, and if you lose the absorption, you're gonna have so much stuff in the lumen, will attract water, leading to diarrhea, okay? So rotavirus destroys the villi, leading to diarrhea. And another thing is when it destroys the brush border, remember, what do you have on the brush border? Other than the actual absorption, you have enzymes on the brush border that help you to digest. One of those is the lactase enzyme, which helps you digest lactose, okay? So when someone gets rotavirus and they get villus atrophy, this destruction of the villi and the brush border gets rid of the enzyme. And other than the diarrhea that they also get lactose intolerance, which is usually transient, but it is significant, okay? You also have an enterotoxin that the virus produces. It has this specific protein that acts as an enterotoxin, leading to ions and water going into the lumen. Remember, anytime you see enterotoxin, just think of ions and water going into the lumen, okay? And you also have a third thing, which is activation of the enteric nervous system, leading to secretion of fluid and electrolytes. So rotavirus has villus atrophy, enterotoxin, and activation of the enteric nervous system. How do these patients present? They get fever, abdominal pain, and vomiting, followed by severe watery diarrhea. Remember, you don't have any invasion or destruction of the tissue. You have atrophy of the villi, you're kind of squishing the villi, and you have enterotoxin, so it's watery diarrhea. The disease usually lasts from 3 to 9 days, and it may be asymptomatic in patients under 6 months or older than 5 years. Okay? Remember what we said, it is usually affecting the children less than 5 years of age. So anyone who's older than 5 may have a way milder disease and may even be asymptomatic. And rarely, rotavirus can lead to a complication which is necrotizing enterocolitis. So for this, just think of a child. Usually the case would be a 4-year-old kid, okay, who's coming with watery diarrhea. They go to daycare, okay, and a few other kids in this kid's daycare also have diarrhea. So when you see this picture, immediately think of rotavirus, okay? A child less than 5 years presenting with diarrhea, usually going to daycare, and a lot of kids around him also have the same presentation. How do you diagnose rotavirus? You can detect the viral antigens in stool specimens by using ELISA or latex agglutination. You can also use electron microscopy where you will see the virions. Remember the wheel shape that we talked about, the pirate ship steering wheel. Can also use molecular assays for serotyping, but this is for public health services only. So why would you want to know the serotype, the specific type of rotavirus? Only for public health. Like if you have an outbreak in a specific area, you want to know exactly what serotype is causing that outbreak, you would do molecular assays, but not really done that much, only for public health. Um, how do you manage rotavirus infection? You rehydrate and replace electrolytes. This will be the case for for a lot of the infections that we talk about in these lectures anyway. Even in the previous lecture, in the bacteria part, okay, the most important thing is to rehydrate. And something I did forget to mention in cholera, when we talked about cholera, because we said that they lose so much volume in the stool, okay, and they may even get hypovolemic shock. Most important thing to do in cholera is to rehydrate. And this is also important in rotavirus, okay? And another thing that's important is prevention. So proper hygiene, hand hygiene, food hygiene, environment, you isolate the cases, you vaccinate, since we have a vaccine to, this will help us to have a less severe infection. And then there's something called cohort nursing, which is basically you're gonna get all of the kids that are infected by this rotavirus, especially if they're infected from the same source, okay? You get them, you put them together, and you treat them together. So you're kind of just taking all of them, putting them, having a little party together. They're all infected anyway, so you just put them together, isolate them together, and treat them, okay? And as we said, we have a vaccine. We actually have two different vaccines. One of them is a live attenuated vaccine, and the other is a hybrid vaccine. The attenuated vaccine is called Rotarix. This one is given in 2 doses. The hybrid vaccine is called Rotatec and is given in 3 doses. What we mean by hybrid is that the vaccine has components from animal rotavirus as well as human rotavirus. The attenuated one, which is the first one, is only human. The hybrid means you have a mix of two things. So the hybrid vaccine has animal and human. Attenuated is called Rotarix, while hybrid is called Rotatec. Now, an important thing is that you do not offer this vaccine to patients with a history of intussusception because the rotavirus vaccine has been found to lead to intussusception in some patients. Um, it's a risk factor. So if you have a kid with a history of intussusception, avoid giving the rotavirus vaccine because it may, trigger another attack of intussusception or put them at risk, which they already are at risk if they've had it before. Another thing is that you give the first dose of the rotavirus vaccine before 15 weeks of age, and children should receive all of the doses before they turn 18 months old. Okay, we're done with rotavirus. Now the next agent. Okay, so this is norovirus. And don't confuse This picture with the rotavirus picture, look at the border. Okay, the spikes are less like prominent, they're fuzzy in appearance. The other one, you could see clear spikes, but here they're kind of fuzzy. Okay, so this is norovirus. Now, norovirus is part of the Calliciviridae family. These are positive single-stranded RNA and they are non-enveloped. Again, they're naked, just like rotavirus. Okay, they cannot have an envelope if they're gonna infect the GI. Um, and okay, so remember in rotavirus, it was also RNA, and we said rota, R for RNA. Here you have noro, you also have an R, so RNA. Okay, and this affects the very young and the elderly. And when they get it, they may require rehydration. As we said in most of these GI infections, you need to rehydrate. How is it transmitted? It is transmitted through fecal-oral route, just like most of these agents anyway. And it can also be transmitted from direct person-to-person spread or contaminated surfaces. It is highly contagious. So if you have an outbreak of norovirus in a specific setting, it's very contagious. It will go around and infect almost everyone. Um, Something about norovirus is that it is extremely stable, just like rotavirus, because they're both naked viruses, okay? Makes them very strong and very stable in environments. They resist freezing, they resist heat, acidic environment. They also resist antiseptic and disinfecting solutions, even chlorine. So you can see how difficult they are to get rid of, okay? We do have genogroups. Remember, we had serogroups in rotavirus. We had serogroups, and the most important one was serogroup A. In norovirus, we have genogroups. Yeah, we have genogroups, okay? The ones that cause infection in humans are genogroups 1 and 2. Very, very important key in any question or case scenario you get is when you see cruise ship. If you see cruise ship, this is norovirus until proven otherwise, okay? So it causes outbreaks in settings where you have a lot of people coming together eating same food, like in schools, resorts, hospitals, nursing homes, restaurants, and cruise ships. Very important to remember resorts and cruise ships. This will almost always be the key thing in the question that will hint towards norovirus. Okay, cruise. Um, you also have waterborne outbreaks associated with genogroup 1. So basically, you can get it from contaminated food or water, okay? As we said here, contaminated food or water. And this specific form of the disease is associated with genogroup 1, while the disease that you get in a healthcare setting is related to genogroup 2. I don't think this is a very important point, but I just mentioned it for completion. And remember what we said in rotavirus, that rotavirus is very common in the developing countries. Norovirus is common in developed countries. Because why is that? Why is it very common in developed countries now? Because we have a rotavirus vaccine. So norovirus has become more common than rota in developed countries because of the vaccine. How does it cause diarrhea? The pathogenesis is not really understood, but there may be a compromise of the brush border, just like what we saw in rota. Remember, the rota also caused villus atrophy and destroyed the brush border. You may see a similar picture in norovirus. And another thing, other than destroying the brush border and leading to diarrhea, it can also lead to vomiting by delaying gastric emptying. Okay, so this is kind of something new. We haven't really seen this yet in all of these lectures. So brush border compromise leading to diarrhea and delayed gastric emptying leading to vomiting. So the patients present with nausea, vomiting, diarrhea, abdominal cramps, and they may have a fever. They may or may not have a fever and headache. And something, a key is that children often vomit more than adults. And this is something that Dr. Muhabbat emphasized for some reason. So just know it. Just know that children present with vomiting more than adults. Okay? You have this virus being shed into the stool for about 2 weeks, even after symptoms have ceased. And remember, it's very contagious and difficult to get rid of. So even after the symptoms have stopped, these patients may still be shedding the virus in their stool. And unfortunately, the immunity is short-lived and it's not protective. Remember, we said in rotavirus, there is some kind of protection that if you get infected once again, the infection will be milder. But in norovirus, there is really no protection at all. Like, if someone gets it, they get immunity for a very short period of time, and then it's like nothing happened. They may get the infection again, and it may still be as severe as the first one. How do you diagnose it? Again, it's a clinical diagnosis, okay? Just like almost all of the bacteria and the agents we talked about so far. We do have a specific criteria for diagnosing norovirus. It's called Kaplan criteria, and it has these 4 points. First one is vomiting. This is seen in more than half of symptomatic cases. Then the incubation period is 24 to 48 hours. So after they get the virus, you wait 24 to 48 hours and they start to show symptoms. Then the duration of illness is usually 12 to 60 hours. And finally, if you do stool culture, there is no bacteria on the culture. Okay, which makes sense. This is a virus. You wouldn't see anything significant on the culture. The culture would be negative. So this is Kaplan criteria to diagnose norovirus. Other than this clinical diagnosis, which is the main thing, you can also do RT-PCR to detect the genome of the virus in stool. You can do immunoelectron microscopy, and you can do ELISA test to detect the virus. But again, main thing is clinical diagnosis. How do you manage norovirus? Rehydration is key. It's very important, okay? And you also want to prevent the infection by hand washing, specifically with soap and water, not alcohol. We can remember we said that the virus is very strong and is very stable and it's resistant to alcohol, okay? But you can use soap and water to get rid of the virus. So, hand washing in norovirus by soap and water, not alcohol sanitizer, okay? Now, next virus is this is enteric adenovirus, okay? Now, enteric adenovirus, adeno, remember we said rota and noro both have R for RNA, but here adeno doesn't have an R. In fact, it has a D, okay? Adeno is for DNA, so this one is a DNA virus, and you can look like ADN, adeno, ADN, okay? DNA. So yeah, noro and rota are RNA viruses, while adenovirus is a double-stranded DNA virus. Again, it's non-enveloped, it's naked, has to be to infect the GI. And we have more than 50 serotypes. Again, just like the previous two, we have a lot of serotypes. The specific types that cause diarrheal disease are types 40 to 42. So 40, 41, 42. This virus affects infants, young children, military recruits, and immunocompromised patients. It's less infectious than rotavirus and norovirus. We said that those two are very difficult to get rid of and they're contagious. Adenovirus is less infectious, and that's why it usually affects more susceptible individuals. And the clinical characteristic is protracted watery diarrhea. Okay? And this is a key feature in this disease. Protracted basically means, just a second. Okay, so protracted watery diarrhea, protracted means that it's a long time. Okay, so it lasts for a relatively longer period of time. So if you see someone with diarrhea that lasts for a long time, protracted diarrhea, think of adenovirus, all right? Other characteristics that they present with, um, they can get vomiting, low-grade fever, and mild dehydration, but mainly watery diarrhea. And this is what the virus looks like. It's icosahedral, basically it's the shape of the virus, okay? Just be able to recognize this picture. It looks very different than the previous two. Um, yeah. Now, how does it cause diarrhea? It infects mucoepithelial cells. So, adenovirus, as a virus in general, it infects mucoepithelial cells. And we know that these mucoepithelial cells are not just found in the GI, they're found in a lot of different areas around the body. they're found in the respiratory tract, they're also found in the eye, okay? So adenovirus infects these mucoepithelial cells in different locations. And depending on the tropism of the specific group of these viruses, it will present with a different type of disease. Tropism is basically which tissue in which location does it affect. So if you acquire the virus from by aerosol, so from the air, it goes into the respiratory tract and infects there, you will end up with a respiratory disease. If it is acquired through fecal matter, it will go into the GI tract and lead to gastroenteritis. And if it is acquired through contaminated fingers and then you touch your eye, it will infect your eye, leading to eye infection by infecting the conjunctiva and the cornea. So adenovirus can infect many different areas, and what we're focusing on today is gastroenteritis. Okay. Now, how do you manage this infection? We don't really have any approved treatment. You only rehydrate, just like what we saw with the previous ones, and you want to prevent it with careful hand washing, chlorination of swimming pools. Basically, you want to reduce the transmission of adenovirus. How do you diagnose it? You can do stool antigen test, which is the most common is ELISA. So you're testing the stool to look for the antigens of this virus. You can also do culture, then immunoassay, DNA probes, NATs such as PCR, but all of this is just for data and you don't really use it for diagnosis. An important thing to remember is histology. So if you take a biopsy from the intestine of an infected individual, you will see this very characteristic feature, which is dense basophilic central intranuclear inclusion body. Okay, so basically this is an enterocyte. I don't know why the text here is so small. I'm sorry, it should be bigger. But um, you have a nucleus and you have intranuclear inclusion body, and this inclusion body is dense, it's basophilic, and it's central and inside the nucleus. Okay, so dense, basophilic, central, intranuclear inclusion body. And this inclusion body contains the viral DNA and proteins, and it's found within the infected epithelial cell. These inclusions are very similar to the ones that you see in cytomegalovirus infection, but the key thing is that in adenovirus, you do not have cellular enlargement. You do have cellular enlargement in cytomegalovirus because from the name, cytomegaly, okay? But in adenovirus, you do not have enlargement of the cells. You only have these inclusion bodies, and I highly recommend you remember this description, okay? Dense basophilic intranuclear inclusions. And also remember this picture. The arrow here is pointing at the inclusion. Okay, so we are done with viruses, and now we will move on to parasites. We'll talk about Giardia lamblia, Entamoeba histolytica, Cryptosporidium, Parvum, and Strongyloides stercoralis. Okay, first organism. This is Giardia lamblia, and always remember that it has a face, okay? Giardiasis or Giardia has a face. So this is the trophozoite, and this is the cyst. You can see it has like eyes and a mouth, and this one too, it has eyes and a mouth. So just remember, if you see a face looking at you, it's Giardia, okay? Now, back to sketchy. This is sketchy for Giardia. Look at this picture here, the trophozoite, with the face looking at you, and they're in water, okay? They're drinking from this contaminated water. It does not look clean. It has poop in it. And you also have the cysts over here. So, what is Giardia? It is a parasite, okay? It is a protozoan, and it is flagellated. It has two forms, the cyst and the trophozoite. The cyst is the infective form, and trophozoite is the vegetative form, and they're both diagnostic. Infective cyst basically means that someone gets infected, what causes the infection is the cyst. What are common reservoirs of this protozoan? It's found in humans. It's also found in wild animals such as beavers, and as well as domestic animals in contaminated stream water. How is it transmitted? Through fecally contaminated water. The water has the cyst, okay? So transmission is through fecally contaminated water. Remember the sketch picture with the poop here, the stool and water, okay? Fecally contaminated water. It can also be transmitted through hand-to-mouth transfer of the cysts among infants and children because, again, kids don't wash their hands, so their hands are not clean. They put it in their mouth. Yeah. Okay, and also some sexual practices. So, very important to know that the infective stage is the cyst, and you also have a trophozoite, which is the vegetative stage, and they are both diagnostic. And reservoirs for this protozoan are both humans and wild animals, and it's mainly acquired through fecally contaminated water, which has the cyst. Okay? What is the life cycle of Giardia? Remember that the life cycle is direct. Okay? This is something that Dr. Mohabbat loves to emphasize. So it's a direct life cycle. Now, you ingest the cyst, okay, and when the cyst goes into your GI tract, the trophozoite will then be released from the cyst, and the trophozoite can attach to the brush border. How does it do that? Uh, it has these ventral disc. The ventral disc is part of the trophozoite that kind of like allows it to attach onto the brush border. It's like a suction thing that just makes it stick on. Okay? And then it uses its flagella to create hemodynamic forces. It can also bind to lectin proteins on the surface of the brush border. So the trophozoite attaches to brush border by three things: ventral disc, flagella, and lectin by binding to lectin proteins. The trophozoites are just attaching there and they're just sitting there. They're not invasive and they do not produce a toxin. So how do they produce diarrhea if they're not producing a toxin and they're not invading? Just them being there and sitting on the brush border will disrupt the brush border, leading to villus atrophy, resulting in watery diarrhea. Okay? This is similar to a lot of the organisms that we saw previously. Just it sitting there will uh, cause villus atrophy, leading to diarrhea. But you do not have a toxin or invasion. Okay? And yeah, okay. So when someone has a Giardia infection, it may be asymptomatic or it may cause acute symptoms or chronic symptoms. So either it's asymptomatic, it causes acute symptoms or chronic symptoms. The symptoms that these patients get are foul smelling watery diarrhea, fat malabsorption, abdominal cramps, flatulence, steatorrhea, epigastric pain. This is very descriptive. If you see someone coming with foul smelling watery diarrhea and fat in the stool, they cannot absorb fat. They have deficiency of all of the fat soluble vitamins. Then think of Giardia. As we said, it can also lead to a chronic disease with multiple relapses. And why is that? Because it can do something which is called antigenic variation. If you remember from PUD and from previous micro lectures, basically antigenic variation is that the organism can change the surface proteins and be able to hide from the immune system. So Giardia can do that, and this can lead to chronic disease. But just remember the description of the presentation. Foul smelling, watery diarrhea, fat malabsorption, steatorrhea. Very important description, okay? How do you prevent Giardia? You need to properly dispose of human waste because if certain countries don't have proper disposal, like if the human waste and stool goes into the river or the drinking water, contaminates this water, and then when someone drinks it, they get the infection. So you need to have proper disposal of waste. It's also important to wash hands, specifically with soap and water, and also to wash vegetables and boil or filter water before drinking. How is it diagnosed? You get a stool specimen and you look for the cyst and trophozoites under the microscope. And it's very important to get multiple stool samples, at least 3 samples, okay? Why? Because the cysts are not always going to be in the stool. They may be shed at different times. So you may get a stool sample at a time where the cyst is not in the stool, and you think, oh, like they don't have anything, you know? So no, they do. It's just that the cyst is not shed at that specific time. So you need to get multiple samples, okay? So you look for the trophozoite and the cyst in the stool under microscopy. You can also look for the trophozoites in a duodenal aspirate. And you can get a biopsy of the small intestine. So you can do all of these to look under the microscope and see these forms of the organism. You can also use fecal antigen detection by immunoelectrophoresis, enzyme immunoassay, immunochromatography. Basically, you're looking for the antigen in the stool. There are other things like NATs, DNA probes, PCR, but most important is stool specimen to look for cysts and trophozoites. And remember the pictures, trophozoite and cyst. And if you see a face looking at you, it's Giardia, okay? Back to the sketchy picture, you have contaminated water, you have the trophozoites, you have the cysts over here, you have this stool in the water, and you have the stool here that he's sitting on is yellow because of steatorrhea. And yeah, this guy is pinching his nose because of the foul smelling diarrhea. And that's pretty much it for Giardia. Now, next organism. This is Entamoeba histolytica. Um, this is a trophozoite and this is the cyst. Okay, if you see this circle with multiple dots inside, this is a trophozoite. And these dots are RBCs. Now, this is the sketchy for Entamoeba. Look at this. This looks like this picture. So this is a trophozoite with the RBCs inside. Okay. Now, Entamoeba histolytica is also a parasite. It's a protozoan, and it moves using pseudopods. Remember, Giardia moved with flagella. Entamoeba histolytica moves with pseudopods. You have two forms. Again, just like Giardia, you have trophozoite and cyst. Again, the cyst is the infective stage. Trophozoite is vegetative, and both of them are diagnostic. Amoeba histolytica is endemic in certain countries, specifically developing countries as well as tropics and subtropics. The common reservoir is humans. In Giardia, it was humans and wild animals like beaver, but here it's humans. And you do have some non-pathogenic strains. So you have Entamoeba histolytica, but you also have Entamoeba dispar, Entamoeba coli, and Entamoeba hartmanni. E. coli is not E. coli, Escherichia coli, it's Entamoeba coli. And these three species are not pathogenic. The pathogenic one that we're going to talk about is histolytica. How is it transmitted? It is through fecal-oral route. Basically, you're ingesting the mature cyst in contaminated food, water, fruits, or vegetables. Similar to Giardia, you're ingesting the cyst from contaminated sources fecal-orally. There is also oroanal through some sexual practices. They get the trophozoite, and when they get it, the trophozoite can cause an cutaneous amoebiasis. Um, in some cases, can also be transmitted through a vector by domestic flies. Basically, if you have your food exposed and you have flies moving around carrying this protozoan, if this fly, sits on your food, it can contaminate this food. Okay, but mainly it's fecal-oral. What is the life cycle? Again, just like Giardia, the life cycle is direct. The infective stage is the cyst. The cyst is ingested, and then when it goes into the GI tract, it releases the trophozoite from the cyst, and then it causes local necrosis in the large intestine by a cytotoxin. So the trophozoite in this case produces the cytotoxin. In Giardia, it did not produce a toxin, it was just sitting there. Here in Entamoeba, the trophozoite produces a toxin. Cytotoxin causes necrosis. When you have necrosis, you have loss of cells and you have inflammation and you have bloody diarrhea. Another thing in the pathogenesis, other than the cytotoxin, is the fact that you have a lot of inflammatory cells and neutrophils coming in. These neutrophils will then die, and the toxic constituents of these neutrophils, after they are lysed and die, will also contribute to tissue destruction. So eventually, you have tissue destruction by cytotoxin and by toxic neutrophil constituents. So now we reach the necrosis, right? Now, when you have extensive local necrosis, you get these ulcerations in the intestinal mucosa. And a key descriptive characteristic of the ulceration is that it is flask-shaped, okay? If you see flask-shaped ulcerations in the intestine, immediately think of Entamoeba histolytica. Um, so again, we have necrosis, ulceration. So all of this means that there is inflammation, there is hemorrhage, okay, because you have ulceration, you have necrosis, and now the mucosa is very like weak, inflamed. It's not very strong and fit for protection. So you may get secondary bacterial infection over this Entamoeba histolytica infection. Now, all this necrosis and inflammation leads to invasion into the deeper mucosa, and eventually the protozoan can reach into the peritoneal cavity. And basically, when it goes deeper and then goes into the peritoneal cavity, it can then reach other organs. Okay, so it can have secondary involvement of other organs. So it can move from being just a GI infection to being systemic infection and affecting multiple organs. Most commonly is the liver. You get an amoebic liver abscess. Okay, it can also affect the lungs, the brain, the heart. So basically, you have extra intestinal amoebiasis, and this is caused by migrating trophozoites. When it goes deeper and into the peritoneal cavity, the trophozoites are moving around the body, reaching all of these organs. How do these patients present? They may be asymptomatic and the infection may be self-limiting, and this is actually the case in most of the time, but they may also be symptomatic. And if it's symptomatic, you either have intestinal amoebiasis, just a local infection, or this intestinal amoebiasis may also have extraintestinal amoebiasis. Okay? The intestinal symptoms will be colitis, abdominal pain, cramps, and dysentery. Okay, dysentery, bloody diarrhea, because remember, we have invasion and we have necrosis and ulceration, so there is blood, there's dysentery. And the extraintestinal amoebiasis, basically, as we said, affects other organs like the liver, lungs, brain, most commonly the liver, and it would form an abscess in all of these organs. And if it's going system in the whole body, then it's going to cause systemic symptoms like fever, leukocytosis, and rigors. How do you prevent entamoeba infection? Again, just like Giardia, adequate human waste disposal, hand washing with soap and water. You want to wash vegetables very well before eating them, and boil or filter water before drinking. How do you diagnose Entamoeba histolytica? You get the stool and you look at it under the microscope. Again, you need multiple specimens because just like Giardia, the cyst may not be in the stool all the time. So you look for the cyst and the trophozoites, and this is to differentiate it from commensal species. So remember how we said at the beginning that we have other species of Entamoeba that are not pathogenic, like Dispar, coli, Hartmanni. Basically, the differentiating thing when you're looking at it under the microscope is that the commensal species, trophozoites, will not have RBCs, okay? If you see trophozoite with RBCs inside, then this is Entamoeba histolytica. So this over here is a trophozoite of Entamoeba histolytica and it has RBCs inside, okay? So this is the pathogenic species. Other thing you can do is enzyme immunoassay to look for fecal antigen and NATs like PCR and DNA probe, but mainly stool microscopy to look for cyst and trophozoite. This is a trophozoite, okay? If you see RBCs, it's a trophozoite, and this is a cyst, right? And if you remember in Shigella, we said that we have something called bacillary dysentery. I think I forgot to mention this term, but it was written in the slide. But the dysentery that we get from Shigella, we call bacillary dysentery because Shigella is a bacilli, okay? So bacillary for bacilli. The difference between amoebic dysentery and bacillary dysentery, obviously amoebic is a protozoan and bacillary is a gram-negative bacteria, but the difference is that amoebic, so you have a patient coming with dysentery, okay? You don't know whether this is entamoeba or Shigella, okay? What are some key things in the history of the patient that may point you towards one of those in a patient coming with dysentery? If it's more insidious in onset, it's more likely to be amoebic. If it's acute, then it's probably bacillary or Shigella. Um, if it's walking dysentery versus lying, basically walking dysentery means that the patient comes into the hospital, into the ER walking, because it's more chronic and more slow onset. So it's been happening for a while and it's gradual and less severe. So the patient will be able to walk and come to the hospital. But here, it's very acute and it's severe, so they'll be very sick and it's not as gradual as this one. Amoebic dysentery is more endemic, remember, tropics and subtropics, while bacillary or Shigella is more epidemic, so you said you get a sudden outbreak. If there's tenesmus, this more likely to be Shigella, and in Shigella you have a lot more polymorphonuclear cells or neutrophils. And obviously, if you see trophozoites or cysts, then this is entamoeba and not Shigella. Back to the sketchy, okay, this is the trophozoite with the RBCs inside. This is the diarrhea. If you look here, this is the colon, okay, and you have all of these ulcerations. And look at this. This is a flask, okay? Don't forget, flask-shaped ulceration is entamoeba histolytica. Um, and the shape of this construction site is in the shape of a liver. And there's also here, looking at the liver, remember amoebic liver abscess as a complication. Okay, next agent. This is Cryptosporidium parvum. So I'm not sure if any of you have reached this far into sketchy in PUD, but this is sketchy for Cryptosporidium. Um, Cryptosporidium is a kind of opportunistic enteric parasite. When you see opportunistic, it means that it affects immunocompromised patients, okay? So it affects patients that have HIV, for example. And usually you see it when the CD4 count goes below 200 in HIV patients. So if this infection affects immunocompetent humans, it's usually self-limiting. It's not really that severe as it is in HIV or immunocompromised patients. So usually when we're talking about them, we're referring to immunocompromised patients. Some parasites that can cause opportunistic enteric infections include all of these. The main one that we're going to talk about is Cryptosporidium parvum. Okay. And other than these like special uh, different types of organisms, you have just the regular organisms that can infect any of us. Okay, so these immunocompromised patients are susceptible to infections by these opportunistic um, organisms, but they're susceptible to infection by any kind of organism in general. So they may still have all of these causing their gastrointestinal symptom. So if you have an immunocompromised patient with gastrointestinal symptoms, it's not directly cryptosporidium and opportunistic infections. It could still be one of these, okay? But cryptosporidium and the opportunistic infections are important to consider in these patients. Now, Cryptosporidium parvum is a protozoan, okay? And it moves by something called epicomplexan. And what this means is that the protozoan has these degradative enzymes that allow it to invade the host cell. So remember, Giardia had flagella, Entamoeba had the pseudopods, and Cryptosporidium has the apicomplexan. Okay? We do have two species of Cryptosporidium. We have Cryptosporidium parvum and Cryptosporidium hominis. Parvum reservoir is humans and animals, while hominis is only human. Hominis for human, okay? How is it transmitted? It's transmitted through contaminated water, so either by drinking it or just recreational activity like swimming in the water. And the key thing and the annoying and scary thing about this is that the regular water filters do not work. So if you're using a filter on the water that you're drinking, usually it will protect you maybe from Giardia, but it will not work against Cryptosporidium. Okay. Other forms of transmission are zoonotic, fecal-oral, oral-anal. Okay. But remember the contaminated water, and if you remember the sketchy, look at the water, pretty contaminated, okay? Who is at risk? As we said, one of the modes of transmission is zoonotic, so veterinary doctors, livestock farmers, animal handlers, these are all at risk. Homosexuals because of some sexual practices, as well as children under 2 years old and the elderly. But again, remember, immunocompromised in general. What is the life cycle? So life cycle is direct, okay? just like the previous two. We do have the infective and diagnostic stages. So we have a sporulated oocyte. This is the infective stage. When it goes inside, it will undergo something excistation, which allows it to release sporozoites. Okay, so if we look here, let's start here. Okay, this is an oocyst. Okay, this oocyst is what infects this person, and it goes inside the GI tract, and then it will release sporozoites. Then the sporozoid will then go into the enterocyte and form something called parasitophorus vacuole, okay, in the enterocyte. So oocyst releases sporozoid. Sporozoid goes to the enterocyte to form this parasitophorus vacuole, and then it will turn into a trophozoite. And this trophozoite will then turn into a type 1 myront or a schizont. And schizont, if you remember, is like a bag, okay? Bag of merozoites. So this schizont will then release merozoites, and these merozoites will then form type 2 myrons. And these type 2 myrons will then differentiate into microgametes and macrogametes, okay? Microgametes are the male gametes and macrogametes are the female gametes. And then these gametes undergo fertilization and form a new oocyst. And this is the sexual part of the cycle. So here you have the gametes, these two, they will fertilize and give you the zygote, okay? Which is the new oocyst, okay? I think I said oocyte, sorry, it's oocyst. And this oocyst is the infective form. You actually have two types of oocyst. You either have oocyst with a thin wall or a thick wall. If it's thin wall, then it can't really protect itself if it goes outside the body. So it stays inside the body and auto-infects this person again. If it has a thick wall, it can leave this person, be shed in the stool, and it has a thick wall, so it's strong enough to go into the stool and then stay there for a while and infect another person. So again, sporulated oocyst is the infective stage. Goes in, you get all of this, and then you go back to the formation of new oocysts that can either reinfect this person or be released in stool and infect other people. Okay? And remember, when the oocyst releases sporozoites, the sporozoites can form something called parasitophorus vacuole in the enterocyte. So this was the life cycle of Cryptosporidium. Okay? Now, how does Cryptosporidium basically, like, how does it cause the diarrhea? When it goes to the brush border, it will attach and replicate there, and it will produce all of the infectious oocysts. So remember how we said that it forms this parasitophorus vacuole? Basically, just by it being there on the enterocyte, it will lead to villus blunting and atrophy, and impaired absorption, increased secretion, and inflammatory response. So all of this will lead to diarrhea. So the patients present with secretory diarrhea because we have increased secretion, impaired absorption, so there's secretory diarrhea. Secretory means that there's some mucus, but it's not blood. You don't have invasion, okay? They may also get some fever, fatigue, myalgia. The oocyst may infect the lungs and the trachea, leading to cough. And these patients may get dehydration, extreme weight loss because they have diarrhea, okay? And again, in immunocompromised, this infection is generally immunocompromised anyway, so yeah. How do you diagnose it? You use a modified acid-fast stain. This is acid-fast stain, okay? And these are the oocysts in the acid-fast stain. You can also use immunofluorescence staining. You're using monoclonal antibodies against the oocyst wall to detect them. You can use lateral flow immunoassay, which is this picture over here, to basically detect the antigen of Cryptosporidium species. And you can use something called immunochromatographic assays or NATs. But remember the modified acid-fast stain, and remember this picture for Cryptosporidium. And if you look at this, okay, look how dark and blue the background is, and then the protozoan is like pink and like bright. Okay, just remember this picture. Blue background and these pink um, crystals, okay? It kind of looks similar to this. Like, look at how this looks and look at how this looks. Looks similar to it, all right? So that was it for Cryptosporidium. Now on to our next parasite. Okay, this is Strongyloides stercoralis. Okay, so remember, it's a worm. So the ones we just discussed were protozoan. They were cellular. But this one is multicellular. It's a worm. This is sketchy. Okay, for this. This guy over here on the bottom right is Strongyloides because he's a strong guy. Okay. Now, what is Strongyloides? It's a roundworm, so it's a nematode. It's a facultative parasite, and what that means is that you can have a free-living, non-parasitic cycle outside the human host. So it does not need a host. It can just freely live outside the host. The eggs are not seen in the feces. What you see in the feces are actually the larvae. Look at this, okay? This is the stool over here. Just imagine it's a stool. It's the diarrhea. And what you see in the stool is the larva, okay? Not the eggs. You do have two forms of the larva. You have rhabditiform larva and filariform. The rhabditiform is non-infective and filariform is the infective. So which form of the larva is infective is filariform. So the larva can mature into filariform inside the intestine and lead to autoinfection. So you have larva in stool, specifically the filariform, that's how it infects other people. But you can also have filariform forming inside the intestine and auto-infect the same individual, okay? So the filariform can either go into the stool and infect other people or stay inside the inside the intestine and auto-infect the same person. How is infection acquired? It's acquired through skin penetration from contaminated soil or acquired by autoinfection from the filariform being inside the intestine. And rarely it can be due to organ transplant, but pretty rare. Remember skin penetration in contaminated soil as well as autoinfection because of the filariform. What are risk factors for strongyloides? Someone who works as a farmer or field worker because they may be exposed to contaminated soil. And also someone who's immunosuppressed like HIV, AIDS patients, malnutrition, and corticosteroid therapy. And Dr. Mohabbat emphasized corticosteroid therapy as a key hint in questions. So I would remember steroid therapy for strongyloides, just in case. Life cycle. We have a female worm that can lay eggs without fertilization. So the female worm here, okay, does not need a male worm to fertilize it. It can just lay eggs on its own. And then this egg can then form into a larva. Now, this larva, which is the rhabditiform larva, it has three different fates. It can either turn into a filariform larva that will stay inside the infection and, stay inside the intestine of this person and reinfect them, okay, autoinfection. Or the rhabditiform larva can turn into a filariform larva that is released into the stool and then contaminates the soil and infects another person. Or it can turn into a free living adult, so it can grow up and become an adult that will go outside into the stool as well and live a non-parasitic life cycle outside. Okay, so the larva can either auto-infect the same person or be released into the stool and infect another person, or be released into the stool, grow into an adult, and just live there freely, not as a parasite. How does strongyloides present? You have three main presentations. First one is acute strongyloides. This is seen in children. It's manifested as diarrhea, and these children get low plasma proteins or hypoproteinemia, low plasma potassium or hypokalemia, and larva occurrence. Okay, larva occurrence is you see the worm. It looks like there's worm under the skin. Okay, so this is skin. Like maybe it's the leg or the hand, whatever. You see the larva under the skin. This is called larva occurrence. Okay, so acute strongyloides. There's hypoproteinemia, hypokalemia, and larva occurrence, and these children usually get diarrhea. There's also chronic, uncomplicated strongyloides. And they get epigastric pain, episodic diarrhea, and they also get recurrent hives. They have the same larva occurrence that's seen in acute, okay? So, acute, hyperproteinemia, hypokalemia, and larva occurrence, while chronic, they get recurrent hives and larva occurrence, okay? Both of them may have diarrhea. The third presentation is disseminated strongyloides infection. So if we go back to the sketchy picture and you look at this arrow that's like going up and then coming back down, that's because when when it infects a person, we have penetration of the skin, like through the foot, for example, and then it goes into the blood and then goes to the lungs, and then it goes up the lungs, the bronchi, into the like the pharynx, and then it will be swallowed, go down the GI tract, and that's how it reaches the GI tract. So throughout its journey, it went to the lungs, right? So the third presentation is a disseminated infection, and this is also called hyperinfective syndrome. And these patients present with sepsis, respiratory symptoms, and gut signs. So why do they get respiratory symptoms? Because we just said when the journey of the parasite as it's infecting, it passes by the lung. So they may get respiratory symptoms and also sepsis. Disseminated strongyloides is usually seen in immunocompromised or immunosuppressed patients. That's what allows it to spread so easily. And it has a high case fatality rate. Some other manifestations of strongyloides include paralytic ileus, which may lead to constipation. Remember, we said here in acute and chronic strongyloides, they present with diarrhea, but sometimes strongyloides can lead to paralytic ileus, presenting as constipation instead of diarrhea. And again, severe diarrhea, pneumonia, pulmonary hemorrhage, all of these we talked about. How do you diagnose strongyloides? You look at the larva in the feces or the stool. Okay, remember, it's not the egg. You do not have the egg in the stool. You have the larva in the stool. So you look at it under the microscope, and this is what it looks like. This is the fillariform larva of strongyloides under the microscope. You can also use serology, like ELISA, to detect the antigen antibodies in the blood, and you can culture, but culture is not really done that much. It's not very helpful. It's only helpful in places with low resources. A place with no ELISA, not very advanced techniques, they may use the culture, which is called Harada-Mori filter paper method. This is the Harada-Mori culture. Basically, there's a strip. You put the strip in the stool, and then you put it inside this tube where you have this water, and you wait for the larva to appear in the water, okay? But again, this is only in low resource settings. And you also have another method, which is molecular assays. And molecular assays is actually it's an important technique in diagnosis, okay? Molecular assays. How do you prevent strongyloides? You need to have strict infection control measures, especially if you find an index patient with hyperinfection syndrome. You want to make sure to isolate them and do all the protective measures, especially when handling their stool, saliva, vomitus, and body fluids, because the body fluids may contain the infectious larva, okay? And you want to educate patients. Have them wear shoes because remember, it's acquired by penetration of the skin in soil, so wear shoes in soil, and proper sanitation and waste disposal is also important. Back to sketchy. Okay, this is the strong guy for strongyloides. We have the larvae in the stool, not the eggs. Okay, and we're done with the parasites. We're actually done with the specific infections, and we're moving into kind of a different category of the microbiology in GI, which is food poisoning, okay? And we have specific organisms here. We have Staph aureus, Bacillus cereus, and Clostridium botulinum. It's a different presentation from the previous ones. In general, what is food poisoning? It is self-limiting diarrhea or diarrhea with vomiting, usually no fever, okay? So food poisoning does not present with fever. It's usually diarrhea or diarrhea and vomiting. We have two mechanisms. Either we're ingesting preformed toxins or we're ingesting spores. So when we're ingesting preformed toxins, basically the toxin is what's causing the diarrhea, okay? If you're eating the toxin ready, then the toxin will go in and immediately cause diarrhea, so it has a very short onset. While if you ingest spores, this may take some time to develop and give the disease, okay? So, two mechanisms of food poisoning: bacterial in ingesting preformed toxins or ingesting spores. Which cases would you see ingesting preformed toxins? Specifically in Staph aureus enterotoxin and Bacillus cereus emetic toxin. These two will have the toxin preformed and then it will be ingested and cause disease. And the idea is, if you get a question, okay, it will be someone coming with, diarrhea or vomiting, like a few hours, maybe like 5 hours after they ate at this gathering. Okay, maybe they ate salad or they ate chicken, and then they presented with these symptoms. And you will see many people presenting with similar symptoms if they ate food from the same source. Okay. And again, symptoms present within hours. The ingestion of spores, however, is what you see in Clostridium botulinum infection, and we will talk more details about this in a few slides. What are the risk factors for food poisoning? Eating contaminated food or food that was made by a contaminated person or with contaminated utensils. Another thing is leaving food exposed or outside, not refrigerated, basically leaving food in a temperature which is in the danger zone. Danger zone of temperature is between 5 degrees Celsius and 60 degrees Celsius. If you leave food outside in this temperature for a long time, that's not good, okay? So you need to either heat it above 60 degrees Celsius or refrigerate it below 5 degrees Celsius in order to prevent the bacteria from growing, because in between these two temperatures, the bacteria can freely grow in the food. And the key thing in food poisoning is that prevention is very important, okay? Okay, now this organism did not have a picture in the slides, but I added the sketchy picture if any of you know what this is. Yep, this is Staph aureus. So, Staph aureus food poisoning, as we said in the last slide, is due to preformed toxins. And if it's preformed toxins, the infection will be very quick. It will be within 1 to 6 hours. They will present with nausea, vomiting, abdominal cramps, and they may or may not have diarrhea. But they do not have fever, okay? Food poisoning does not present with fever. This is in contrast to the infections that we talked about at the beginning of the lecture, okay? Those may have fever, but food poisoning does not have fever. How do you get the Staph aureus food poisoning? From dairy products, meat products, eggs, salads. Eggs and salads are very important, okay? They're very important keywords, especially in questions. Eggs and salads. Again, you have a preformed toxin, so it's an enterotoxin. You have different types of enterotoxins. The ones that are heat stable are A to E, okay? Enterotoxin A to E are heat stable, so even if you, okay, so let's say you prepared food, okay, and then you left this food outside, or someone who was contaminated, prepared the food, so now the Staph aureus is in the food, okay, and then you heated this food, um, so you killed some of the bacteria. But okay, you made the food that had Staph aureus and then you heated it, you killed the bacteria. If someone who's contaminated came again after you did that, and prepared the food or held it or used utensils around it that is contaminated, they were infected with Staph aureus again. And this time you leave the food outside, okay, in the temperature that we talked about. The bacteria will keep on dividing, okay, and forming the toxin. If you get this food after leaving it outside in this temperature for a while and you heat it again, you will kill the bacteria that grew in the past like couple hours. You will kill the bacteria, but all of the toxins that the bacteria produced in the food will not be destroyed by the heat when you reheat the food, okay? The toxins will stay because these enterotoxins A to E are heat stable, okay? Um, and how do these toxins act? They act as super antigens, leading to cytokine storm. They also act on GI nerve endings, stimulating the vomiting center. That's why these patients present with vomiting, okay? How is it diagnosed? Clinical diagnosis. Culture is not really done. It may be done to screen for a toxin. Or it's maybe done if you're suspecting, like if you're not sure what organism caused and you want to do it for public health purposes, you could culture, but usually diagnosis is just clinical, not by culture. Okay, now what is this organism? It's kind of a vague picture, but it's a gram-positive bacillus. So this is Bacillus cereus. Um, Bacillus cereus food poisoning is kind of okay. You have a very characteristic feature, which is reheated rice or fried rice syndrome. What is Bacillus cereus? It's a motile gram-positive bacilli. Okay, look at this. It's bacilli and it's gram-positive, and it's motile. If you remember the sketchy picture, just for like memory to jog your memory, you look at this guy over here, holding a bowl of rice because Bacillus cereus food poisoning is what you see when someone eats reheated rice. How do these patients present? They have two different presentations depending on the toxin. So you leave the rice and then you reheat the rice. This basically means that the patient could get Bacillus cereus food poisoning. Now, the Bacillus cereus food poisoning can present in one of two ways. It can either be an emetic syndrome where they have vomiting, or it can be a diarrheal illness where they have diarrhea. What determines which kind of disease they get? The toxin that is made. So, or the pathogenesis, okay? In the emetic syndrome where they get vomiting, it's because they eat a stable toxin, a highly stable toxin that's resistant to high temperatures, resistant to digestive enzymes and pH. So basically, if they eat this toxin, they get vomiting and emetic syndrome. But if they eat the spores, these spores will lead to diarrheal illness because they bypass the pH of the stomach and they get deeper into the GI and lead to diarrhea. Okay, so toxin, vomiting, spores, diarrhea, and Bacillus cereus is seen in reheated rice. Very important clue in the question. Okay, reheated rice or fried rice. Now again, this is what we said here: the emetic versus the diarrheal form. Um, the emetic form, because it's the toxin, so it has a shorter incubation period because the toxin is preformed, while the diarrheal, because of it's because of the spore, it takes more time. And again, emetic, there's vomiting from the toxin, while diarrheal, there's diarrhea from the spore. Now, the next organism, again, did not have a picture, so this is a sketchy if anyone knows it. This is Clostridium botulinum. So food poisoning from Clostridium botulinum is called botulism. How, what causes this disease? It's the botulinum toxin. You know this is very classic. There's home canned foods or the ingestion of honey by infants. Basically, you have the toxin in the canned foods, or you have the spores in the honey. And when someone eats these foods, they can get botulinum toxin. And the key thing about the botulinum toxin is that it causes a flaccid paralysis, particularly descending paralysis. So, food poisoning by the botulinum toxin leads to descending flaccid paralysis. So these patients present with double vision or blurred vision. They get drooping eyelids, slurred speech, difficulty swallowing, and it starts, it's descending, so it starts in the face. So if you see someone who eats something canned, and then 18 to 36 hours later, they start to get double vision and drooping eyelids, slurry speech, you want to suspect botulism, okay? And the feared complication is it eventually progressing into respiratory muscle weakness, leading to respiratory failure and even death. And the key thing is home canned foods, or if an infant eats honey. Why? Because honey normally has the spores of Clostridium botulinum. As adults, we can destroy the spores and be fine, completely fine by eating honey, okay? But infants, because their GI tract and their microbiota and their GI is still underdeveloped, if they eat these spores of Clostridium botulinum in honey, okay, they cannot destroy them. So they have the spores from honey, and the spores eventually germinate, leading to botulism. How do the toxins work? Basically, this is a neuromuscular junction. You know that this is a muscle, this is a nerve axon terminal. You have acetylcholine. Normally, acetylcholine will be released and lead to muscle contraction. Botulinum toxin blocks the release of acetylcholine. So if you can't release acetylcholine, you don't get muscle contraction, and that's why there is flaccid paralysis. We do have different types of botulism, foodborne botulism, infant botulism, basically what we talked about in the previous slide. And there is iatrogenic botulism. This is due to overdose of Botox. Basically, if someone gets Botox in a like somewhere that's not certified, not very clean, not very like high, policy, whatever. If you get it, they get it commercially done in cheaper places. People are not very like proficient with it. They can give too much Botox, okay, and this can lead to iatrogenic botulism. How do you manage botulism? Supportive therapy is key, and you can give antitoxin. The key with antitoxin is that it does not reverse what already happened. Okay, if someone has botulism and like the toxin is preventing the release of acetylcholine, everything that it did so far cannot be reversed. What the antitoxin can do is it can prevent the progression into a more like severe disease. Okay, it just stops it as at that point. Does not prevent. It does not reverse. Okay, what happened happened. It just prevents the progression. And you just prevent the progression and wait until the body gets rid of the toxin itself. Okay, so the key is supportive. And now we will move into the last part of this crash course, which is the antibiotic-associated diarrhea. The key culprit is Clostridium difficile. So I guess you know what this is now. Okay, what is this organism? This is Clostridium difficile. Um, it used to be called Clostridium, now it's called Clostrioides. Just a fun fact. So this is the sketchy for Clostrioides for C. diff. Um, come back to this in a while. So Clostridium difficile is gram-positive spore-forming obligate anaerobic bacilli. So it's gram-positive, it's anaerobic, okay? That's why they're wearing the mask. And it's spore-forming. That's why we have these nuts and spores here. It has a drumstick appearance. You can see it here, okay? The drumstick appearance, this bulging circle, is because of the spores, okay? And C. diff is the most common cause of antibiotic-associated or nosocomial diarrhea. So if you have a patient who recently used antibiotics and suddenly they're presenting with diarrhea, immediately think of C. diff. The thing about the spores of C. diff is that they can persist in the environment for a long time and they are difficult to clean and get rid of. And that's why if you have a patient that is hospitalized and they get C. diff infection, basically the room is like contaminated with spores. There's spores all around it. So after you discharge this patient, before you get a new patient in, you need to make sure that you properly clean the room, okay? Because these spores can persist for a long time and you don't want to infect any new patients coming in. And this picture is, you can see gram-positive bacilli, and again here the drumstick appearance. What are the toxins that are produced? So basically, C. diff produces toxins. We have two types of toxin. We have toxin A and toxin B. Toxin A is an enterotoxin, while toxin B is a cytotoxin. And you can also have sometimes some strains producing binary toxins, basically producing both together. Now, look at this sketchy picture. You can see on the side it's toxin A and the side is toxin B, okay? And these are actin polymers. Toxin B is cytotoxin. So cytotoxin means that it destroys cells and kills them. So basically, toxin B goes to the actin polymers and destroys them. Okay, that's why this kid over here, I don't know if you can see it, but this kid is chewing on these actin polymers, and so it's destroying the structure of the cell, and the cell dies. And when the cell dies, you get the pseudomembrane formation, and that's why you get pseudomembranous colitis. On the other hand, the toxin A is the enterotoxin. Remember what we said at the very beginning. Anytime you see enterotoxin, you think of diarrhea. Okay? So toxin A is what causes the diarrhea. Okay? Toxin A is enterotoxin, causes diarrhea. That's why you have the chocolate diarrhea over here on this side. While toxin B is cytotoxin and it leads to pseudomembrane formation. We do have some genes, okay, that are significant. We call it pathogenicity locus. Basically, you have certain genes that code for certain toxins. So you have a gene that codes for toxin A, you have a gene that codes for toxin B, and it's TCD-A and B respectively, okay? And then you have C and D. The gene D is the gene that encodes for positive regulator of transcription. So basically, D is what encodes for increased production of the toxins, okay? While C is the negative regulator, so it stops the production of the toxin. So you can think of it as the gene that's C closes the toxin, okay? It closes it and doesn't make any more toxin. But D makes more toxin. And then you have TCDE, which is the gene encoding the toxin disrupting bacterial membrane. So what this means is that this gene encodes a special toxin that disrupts the membrane of C. diff. And when the membrane of C. diff is disrupted, all the toxins that it has inside are released. So E enhances the release of toxin. So you have A for toxin A, B for toxin B, D to increase the production of these toxins, C to stop the production of the toxins, and E to enhance the release of the toxin. And you have a particular strain of C. diff, which is this one, NAP1BI027. This strain is very virulent, okay? Why is that? Because it has a lot of toxin production because it has a mutation in the suppressor gene, which is TCD-C. Remember, C closes the toxin production. In this strain, this C gene is mutated. So you don't have anything that's suppressing the production of toxins. So you have so much toxin being produced. That's why this strain is very virulent and is resistant to fluoroquinolones. Now, how do patients acquire this infection? Basically, it's seen in hospitalized patients. So you think of someone who was hospitalized, someone who received antibiotics recently, which lead to alteration of their gut microbiota. It could also be someone who was exposed to C. diff, like someone who got, for example, you had a patient with C. diff in a hospital room, and then the room was not cleaned properly. You have a new patient coming in, and then they got infected with the spores that were there in the room, okay? Um, you also have some risk factors that make someone susceptible, like if someone does not have a very strong immune system, if someone is immunocompromised. So hospitalized patients, patients who received antibiotics, patients who were exposed to spores of C. diff, and patients who are immunocompromised. This all allows them to acquire C. diff infection. And the way it works with antibiotics is basically if someone takes antibiotics, you're altering the microbiota of that person, and so you're destroying a lot of all the nice bacteria in the gut, and C. diff will then overrule all of these nicer bacteria, okay? And you have a increased colonization of C. diff. Um, Now, when someone has C. diff, it does not always mean that they have diarrhea and, C. diff associated diarrhea. Sometimes they can just be asymptomatic colonizers. Now, which antibiotics specifically are high risk? Clindamycin, cephalosporin, fluoroquinolone, co-amoxiclav. Clindamycin is a very important one for you to know. Always remember, clindamycin puts the patient at risk for C. diff infection. And another key point that you should probably know is that PPIs increase the risk of C. diff. They don't necessarily alter the gut. It's the fact that they weaken the acidity, they reduce acidity in the stomach, and so you lose some of the protective mechanism against C. diff, acquiring C. diff, okay? So just remember that one of the side effects of PPIs is that they increase the risk of C. diff. You should know this in general for the GI block because they might ask about it in pharma for the PPI lecture. So remember it, okay? PPIs increase the risk of C. diff as a side effect. Now, how does the infection happen? Basically, if someone gets the spores via fecal-oral route, okay, either they ingest the organism or the spore, it can go into the intestines, and this, if it's the spore, it will germinate into the actual bacteria. And when the bacteria is in the intestines, it will go down here into the crypts because remember, it's anaerobic, okay? So it will hide inside the crypts where you have little oxygen. And then eventually it will destroy the villi, okay? And we also said we have toxin A and toxin B, so it will destroy the cells. It will lead to the enterotoxin effect and diarrhea, okay? And when the cells are destroyed, you have the pseudomembrane formation. So you have toxin A, which is enterotoxin causing diarrhea, and you have toxin B, which is the cytotoxin, leading to the pseudomembrane over here by killing the enterocytes. Um, so again, as we said, sometimes these people can be colonized by C. diff, but they would be asymptomatic carriers, okay? And if they're asymptomatic, they don't require treatment, okay? However, if they are symptomatic, they require treatment. What are symptoms that they may present with? They present with fever, abdominal pain, non-bloody mucoid, greenish, foul-smelling diarrhea, and elevated white cell count, okay? So when someone has C. diff infection, we have different stages of severity of the disease. It can either be antibiotic-associated diarrhea, just like just basic diarrhea, or it can be antibiotic-associated colitis. So it's diarrhea, but then there's inflammation of the colon. It's more severe. And then the next stage is pseudomembranous colitis, which is even more severe. And finally, the most severe complication of this infection is toxic megacolon, which is very dangerous and it's an emergency. This is what toxic megacolon looks like. It's very huge, very inflamed colon. It could rupture. It's very bad. Okay, it's very dangerous. Um, yeah, so these are the symptoms of C. diff. How do you diagnose C. diff? You can do a stool culture, and basically you can use this agar, which is CCFA, or the C. difficile agar. But the problem with the culture is that it takes 2 to 3 days for growth, and you don't want to wait that long. And you also, like, you may have C. diff in the culture, but that does not mean that this is like a toxigenic strain. So you need to make sure if you have a toxin in the stool, you need to test for the toxin. So the gold standard for diagnosing C. diff is you get the stool, you do the culture, and you do the toxin testing. Toxin testing is the gold standard. How do you do toxin testing? By exotoxin assay, basically to detect the stool in the toxin in the stool. So it uses ELISA or it uses cytotoxicity test. Cytotoxicity test is specific for cytotoxin B, but the more important is ELISA. Okay, so ELISA, you're using antibodies to detect the antigens and to detect to detect toxins A and B. Okay, so this is the ELISA, the exotoxin assay. This is how it's done. Basically, you get the stool sample, you put it here in these strips. GDH is an enzyme that is found in C. diff, okay? So in this, you're detecting the presence of the bacteria, okay? And in these, you're detecting the presence of the toxin. So if you have a reaction here or here, it means it's positive. If both of them, both the GDH and toxin is positive, it means that you probably do have a toxigenic C. diff infection. If they're both negative, then it's unlikely. If one of them is positive and the other is negative, this is like suspicious. Like, why are they not the same? So you need to confirm by doing a C. diff PCR. If the PCR is positive, then it's probably a toxigenic C. diff infection. If it's negative, then this is unlikely. Okay, so remember, gold standard is to look for the toxin in the stool by using this, okay? The exotoxin assay. You can also use NAT or molecular assay to look for toxin gene, but the problem with this is that it detects the gene even if the bacteria is dead. These are the cultures. This is the CA agar and this is the CCFA agar. Now, other things you can do to diagnose C. diff, you can do endoscopy. You would see this picture, this pseudo membrane, okay? You can do biopsy with histology, and you can do some radiologic investigation. How do you manage C. diff? You wanna basically, we know that it's antibiotic associated, right? So you wanna stop the antibiotic that's being given. Okay, if the patient is taking antibiotic and suddenly they get diarrhea, you want to stop that antibiotic, and you want to give IV fluid to rehydrate the patient, which is the case for a lot of these diarrheal illnesses. Then you want to give medications, okay? And this, I would say, is very important for you to remember. You can give fidaxomicin, okay? You can give oral vancomycin or oral metronidazole. Oral vancomycin, you rarely ever give vancomycin orally, usually it's IV. This is maybe the only indication for giving vancomycin orally, okay? Oral vancomycin for C. diff. Very important for you to know. But not IV vancomycin. Don't give IV vancomycin for C. diff because if you give it IV, it will not even reach the GI tract, okay? It will not be helpful. Metronidazole, you can give it either orally or IV because even if IV, metronidazole, like the molecule of it can reach the GI. Vancomycin can't if you give it IV. So, fidaxomicin, oral vancomycin, oral metronidazole, IV metronidazole. Okay, but don't go for IV metronidazole as first option. It's either one of these two, okay? You can also do surgery, specifically if there's megacolon or like very bad complications. Sometimes they can do stool transplant. Basically, they're getting stool from a healthy individual. They're taking all of the healthy bacteria and microbiota from that stool, and they're putting it into like a pill or an enema, and they're giving it to those patients to kind of like restore their microbiota that was lost due to the antibiotic. You can also give bezlotoxumab, which is a monoclonal antibody against C. diff toxin. So you're giving an antibody against the toxin, so you're like capturing the toxin and stopping it. And this is helpful for recurrent C. diff infection. You don't usually go to this as first line. If someone keeps getting C. diff, you can give this bezlotoxumab. Then another thing is when you're giving these medications to treat C. diff, you want to give it in intermittent doses to prevent recurrence because recurrence is pretty common, as we will see here. Okay, so before we continue with that, let's just talk about recurrent C. diff infection. Okay, so by definition, recurrent C. diff infection is getting new episode of symptomatic laboratory confirmed C. diff infection that occurs within 8 weeks of the onset of previous episode after the initial episode resolved. So you get a new episode of C. diff that's confirmed by labs, okay, within 8 weeks of the first episode. And this recurrence is more common in elderly, and it may be reinfection with a new strain or a relapse of the same strain. So back to this point, okay, since you may have risk of recurrence, when you're treating it, you want to give intermittent doses of antibiotics, of these medications, okay? So you give a dose, you stop for a little bit, you give the dose again to prevent recurrence, okay? You don't give one dose and then stop because it could come back. You need to give multiple doses, okay? Another thing is that's important is prevention. So you want to isolate cases, put them under contact precaution, okay? Not airborne, not droplet precaution, no, contact precaution. You also want to clean the room very well with bleach solution, okay? Bleach solution specifically, because bleach is what destroys the spores, okay? Then you want to wash your hands with soap and water and not an alcohol-based hand sanitizer because the spores are not killed by alcohol. They will be removed by soap, okay? You must use soap and water to get rid of the spores, not alcohol. And finally, don't use anti-motility medication for C. diff. Anti-motility is in anti-diarrheal drugs. Don't give them. You don't want to stop the diarrhea. You want it to happen. You want to get rid of all the toxin. If you stop the diarrhea, the toxin will accumulate in the gut and it's not good, okay? So do not give anti-diarrheal. And back to the sketchy picture. Again, here is for this clean sign for clindamycin. This is for metronidazole. Here is for oral vancomycin, okay? Because the door is open. And then you have toxin A for the diarrhea, toxin B, the cytotoxin for the pseudomembrane. And with that, we conclude this GIT microbiology crash course. I hope this helped you guys. Inshallah, I wish you the best of luck in your exam. And if you have any questions at any time, please feel free to reach out to me. This is my email, this is my number. And yeah, best of luck and see you in another PAL lecture, inshallah.